Sir, good morning.
Very good morning.
Very good morning. Good morning, Nagaraj sir. Good morning, Nagaraj sir.
Good morning. Good morning, Mr. Mohan.
Yeah, I think Dr. Jabbar was joined previously.
Yeah.
Right?
Sir has joined.
The doctor is there.
Yeah. Sir, good morning, sir.
Good morning, good morning.
Very good morning, sir.
Good morning, Srinath. Good morning, Murthy.
Yeah,
How are you, sir?
Fine, going on. How is Bangalore now?
It's good. It's better. Safer.
Okay. Good.
Requesting RX event, stop the background music. Anybody from backend of RX event, please stop the background music.
Okay, sir. Okay.
Actually, give me one.
Nagaraj sir, I think the good registration from Tamil Nadu, Kerala, and also Andhra, it has happened.
Karnataka
Very
also,
nice.
sir.
Yeah. And how about the West and others, sir?
So we have a participation from Gujarat and Maharashtra and Bombay City as well. Some few doctors from MPCG, and then good amount of doctors from Nepal also even. And as of now, Delhi, some doctors have joined, and we are expecting some more addition from West Bengal as well as the Odisha. So it's going to be a presence from across the country, sir. Yeah.
Pan India.
Pan India, sir.
Nepal already 16 doctors joined, sir.
Yeah.
From Nepal, Gokul.
Yeah, Nepal.
How about, sir?
16.
Sir, can we attend something? How about the first speaker?
Sir, panel link സാറിന് അയച്ചിടും മുടിയാനിപ്പോ സാർ മെയിലിൽ അയച്ചു വാട്സാപ്പിൽ അയക്കണോ സാറേ?
Praveen, you be on mute. Praveen.
Requesting RX events to give the sharing the screen rights to me, because we have to share the introductory slides.
Good morning, Nagaraj. Good morning.
Good morning, sir.
Good morning, Jabbar sir. I'm audible.
Yeah, you're audible. Very much audible.
You're
Sir.
audible,
Good morning,
sir.
sir.
I think Nagaraj sir, we have to.
Yeah.
Shall we begin, sir, with the
Yes,
permission
please.
of
Yes.
our moderator? And doctor, shall we begin? Shall we start?
Yes, Nagaraj. Yeah. Nagaraj, we should start.
Yeah, I'm just waiting for Dr. Jabbar.
Ready.
Sir,
Yeah, sir is there.
shall we start, sir?
Yeah.
Ready.
Yeah, we'll ask Dr. Jabbar and start.
Yes, sir. Yes, sir. So, very good morning to all the doctors. Let me take this opportunity to introduce myself. This is Shenbaga Nagaraj. I work as Associate Vice President for Diabetes Business Unit for Microlabs. And on behalf of Microlabs, I just would like to welcome our course coordinator as well as the moderator for this entire ADF program, none other than Dr. PK Jabbar. And in fact, I would like to invite all the speakers as well as all the doctors across the country. They are participating in this program. So we have in fact started this academics in diabetes forum the last year. This is the second year we are having this program. And our endeavor is to bring the latest clinical updates and the trends in the field of diabetes through our eminent doctors across the country to disseminate the current scientific happenings among the healthcare professionals in the country. That's our endeavor. As a company, we take this privilege to reach out to all our doctors through this virtual scientific meetings. Since we are in the pandemic, so this is really helping us to reach out to many doctors across the country. And we are delighted to have our speakers. We have a good eminent speakers from across Kerala. Let me welcome Dr. Tushan Thomas. Let me welcome Dr. Anish Ghosh. Let me welcome Dr. P. Jayaprakash, and then Dr. Joe George, and then Dr. Tom Babu, and then we have Dr. Sunil K. Menon and Dr. Vipin, and as well as the Dr. Tituman. So we are going to have 8 speakers in the panel. We are going to have 3 presentations with the directions and guidelines of our moderator, Dr. Jabbar. So now I would like to introduce Dr. PK Jabbar. Before that, I just would like to welcome Mr. B.R. Srinath, who's our Senior Vice President, taking care of the cluster business unit for the diabetes in Microlabs. So he has been associated with us for the last 4 decades, and he's the one who has built many brands and many business units in our company, who's very instrumental for the growth of Microlabs. So let me take this privilege to welcome Mr. B.R. Srinath to say a few words about today's proceedings.
Humble pranams to everyone. Nagaraj, thank you. But in front of all the acharyas who are sitting here, in fact, with great humility, I extend a very, very warm welcome to each one of our speakers today. And most importantly, Dr. Jabbar sir, who, when we approached him last year, helped us start this ADF, and really who is helping us make this a brand name. Extend a very, very hearty welcome to the course coordinator, Dr. Jabbar, and also all the speakers. With humble pranams, sir, please, you have helped us the second year. Please make this very big, and I am certain with this elite speakers and the course coordinator, this is going to become a very big brand. Thank you, Nagaraj, for
Thank you, sir.
along with Mr. Murthy and my managers for initiating this program. And I'm happy that this is a pan-India program. We do a lot of academic activities, and I am certain this ADF is going to become a brand name with all your help. Let us start the academic feast. I welcome all the other audience who are here, other doctors, delegates who are going to listen to the great speakers of the country. Thank you very much.
Thank you, sir. Thank you, Srinath, sir. So now let me take this privilege to introduce our moderator, who doesn't require any introductions, who's a very renowned the international KOL as well as the national KOL, who's a part of many academics program, who's very instrumental in terms of playing a major role in terms of the endocrinology as well as diabetes. So a few words about Dr. Jabbar, and currently working as a professor and the HOD of endocrinology. And also he is working as a director and CEO of the IID, Indian Institute of Diabetes at Trivandrum, Kerala. And also Doctor is a postgraduate teacher as well. And he's a principal investigator for the numerous clinical trials. And he was chairing the session, chairing ESICON in the year 2017 as well. And also he was organizing secretary for RSSGA 2010. Few publications, contributed to various textbooks of medicines. He has 35 papers in journals showing to his credits, and presented papers in various technologies meeting, and regular examiner for various universities as well, for DM and as well as the DNB. And also Dr. B.K. Jabbar is a medical council inspector as well as the DNB assessor. And first of all, I mean, thank you so much, sir, for accepting our invitations on your busy schedule and giving this kind of platform to share this scientific happening, as well as build the image of our organization. Thank you so much, Dr. Jabbar, as well as for moderating and structuring these entire programs, this academic phase. Once again, we are privileged, we are honored, sir, by sharing your time. Now, I welcome Dr. Jabbar to take the proceedings. Over to you, sir.
Thank you, sir. Thank you.
Yeah, good morning and regards from Kerala. And I think we should thank Micro, because Micro is always in the forefront in the academic activities. I remember my interaction started with Srinath probably more than 15 years with one academic activity. All right. Always Micro is very, very active, very straight, and very, very receptive type of company, which I would say.
Thank you.
Okay. And all the time I met Murthy also. Murthy is also almost in the same type of personality. I would say on behalf of entire delegates and my friends who are sitting here, we should thank a big thanks for Micro for their academic activities and for giving us a platform for sharing our academic ideas also. Okay. Now with this, I don't want to introduce the speakers because already done by my friend, Dr. Mr. Naga. Naga is also, he used to call me probably every other day to discuss the progress of the academic or the feast. Very active, and even Praveen was very active. So I'm concluding with one word, big thanks for all the academic help extended to medical fraternity. Okay. And to the today's program, we have a beautiful team of speakers. I would proudly say most of the speakers are my students and my dear friends. Today, see, I can tell you, Sunil is my student. Okay, Joe is my student. The Bibin, Tushant, Titu, all are very closely working with me for the academic activities in Kerala. Right? Okay. And topic I don't want to discuss. See, they have included beautiful topics also for that. After that, we'll have a panel discussion. I hope we can finish within 2 hours. That's our plan of action for today. Without wasting much time, may I invite my friend, Dr. Bibin. You can show the slide or introduction slide of Dr. Bibin. Bibin is one of the gentlemen. He is currently working in Aster Medicity as a senior consultant. He is having all the degrees which are possible for a human being. MBBS, he is having MD, DNB, MRCP, DEM, and he is a member of National Academy of Medical Sciences, and is very closely related to Royal College of Physicians also. And I know he's a very, very good academician. In fact, he would have gone up more and more because of his caliber. And he is a gold medalist. I don't have any surprise at all. He really deserves for that. Very keen interest in academics, administrative activities also, and is one of the master brain behind Kentocon 2020. Just for your information, PACE, Professional Association of Clinical Endocrinologists, we are conducting 2 days of academic mela, virtual mela. If you want to register, if you want to get any information, you can contact Dr. Bibin. He is the organizing secretary. Without wasting much time, may I invite my friend Dr. Bibin for his deliberation. Over to Bibin. Bibin, please. Bibin.
Yes, sir. Thank you, sir, for the kind words. I'm not having that screen share option. Now, somebody will please hand over me the screen share option. Yes. I hope my screen is visible and I'm audible.
Yes.
Yes, sir. Yes, sir.
Yes. Thank you, sir, for the kind introduction. Today, I'll be dealing with the first topic, aggressive management of type 2 diabetes mellitus in India in 2020. So we'll be starting with COVID-19 and diabetes. We have many position statements from different associations regarding COVID-19 and diabetes. We know that people with diabetes are not more likely to get COVID-19 than the general population. But the problem with diabetes is when the patients with diabetes gets an COVID-19 infection, they are having increased chance of experiencing severe symptoms as well as complications from COVID-19. If the diabetes is well managed, the risk of getting severely sick from COVID-19 is same as that of general population. So we should encourage our patients to have a good glycemic control during the COVID-19 times. And the risk is similar for the type 1 as well as type 2 diabetes mellitus patients. So if the patient is already having diabetes mellitus associated with complications, they are more likely to have worse outcomes with diabetes with COVID-19 infection. And if you see the glycemic control, they can have hypos as well as diabetic ketoacidosis, especially if they are having type 1 diabetes mellitus. The problem with viral infection is that it will increase the inflammation as well as tissue edema in people with diabetes mellitus. We know that uncontrolled hyperglycemia can also have the similar kind of inflammatory stress on the body. Both can coexist together to produce a cytokine storm, which can put the patients on increased risk of complications associated with the viral infections like COVID-19 if it is uncontrolled. So what are the precautions or practical aspects that we should take care is, it is important that people with diabetes maintain a good glycemic control. So it will reduce to help the infection as well as the severity. And if the patient is having coexisting heart disease or kidney disease, they need to maintain a good glycemic control as well as take care of the heart disease as well as kidney disease. And we should also give importance to nutrition and adequate protein intake, as well as supplementation of minerals as well as vitamins if they are deficient. And we know that exercise also improve the immunity, but avoid crowded places like gymnasia or swimming pools at the time of COVID-19. With this introduction, I'll be going to the topic proper, why aggressively manage type 2 diabetes mellitus. So that is the point of discussion that I'm going to discuss in the next couple of minutes. So we know that the diabetes is having impact on the body. It can have complications and it can cost the life. And if we see as compared to non-diabetic patient, a diabetic patient can have 14.5 years of life lost because of the diabetes and related complications if it is not well controlled. And if we see around 50% of the patients at the time of diagnosis itself can have complications of diabetes mellitus. Some around 20% of them can have retinopathy. They can have abnormal ECG in 18% of the cases. They can have neuropathy, ischemic changes to the foot, as well as peripheral vascular disease and elevated creatinine in 33% of the cases. So at the time of presentation itself, majority of our patients are having diabetes due to macrovascular complications. And as per the recent IDF guidelines or summary, we can know that around 50% of the diabetes patients are undiagnosed if we consider the entire spectrum of diabetes mellitus. And if we see the diabetes as well as cardiovascular disease risk, diabetes is associated with a 2 to 4-fold increase in the risk of cardiovascular disease compared with the non-diabetic subjects, and approximately 80% of the patients with diabetes develop and die because of the macrovascular disease. So we should control diabetes as well as prevent macrovascular disease. And if we see the microvascular burden of diabetes, we know that what is the most common cause of chronic kidney disease in India. Diabetic kidney disease accounts for 60% of the cases of end-stage kidney disease in India. So we should try to prevent the progression of microalbuminuria to macroalbuminuria as well as CKD. So how to aggressively manage type 2 diabetes mellitus is the next question. So over the years, diabetes management has witnessed changes, especially if you consider the past 2 decades. There's a lot of understanding in the pathophysiology of diabetes mellitus. What are the pathophysiological aspects which contribute to hyperglycemia? What are the new norms of lipid as well as blood pressure management? What are the newer insulins as well as newer OHS with different mechanism of action as well as synergistic actions? What are new treatment algorithms? And all these have together contributed to improved glycemic control as well as non-glycemic benefits like prevention of microalbuminuria as well as cardiovascular protection. So if you see that therapeutic armamentarium of the agents that we can use for management of hyperglycemia, we are having metformin, we are having sulfonylureas, alpha glucosidase inhibitor, thiazolidinediones, DPP4 inhibitors, SGLT2 inhibitors, and the injectable forms we are having GLP-1 agonist, insulin. And there are many other less commonly used agents like pramlintide, bromocriptine, hydroxychloroquine, etc. And then newer drugs in the pipeline for the management of diabetes. But it is not available for routine clinical practice nowadays. And if we see the pathophysiology of hyperglycemia, we know the omnius object by Dr. Ralph DeFranco, and what are the different agents acting on these different hyperglycemic contributors. Like peripheral muscle resistance is reduced by thiazolidinediones as well as metformin. Neurotransmitter dysfunction, the brain is attended by GLP-1 receptor agonist. Hepatic glucose output is reduced by GLP-1 receptor agonist, DPP-4 inhibitor, thiazolidinediones. And the incretin axis is supported by DPP-4 inhibitor, GLP-1 receptor agonist. And to increase the insulin secretion, we are having sulfonylurea, DPP-4 inhibitor, as well as GLP-1. And lipolysis is taken care by thiazolidinediones, and SGLT2 inhibitors act on the kidney to reduce the glucose absorption. But we know that none of these medication can entirely address all the pathophysiological mechanisms which contribute to hyperglycemia. So treating diabetes mellitus as a single drug is always, there's a chance that we may fail to control the blood sugars and address the pathophysiology. So we should hit hard from the beginning with several drugs to address the pathophysiological mechanism which contribute to hyperglycemia and preserve the beta cell function early. So this is the newer concept of managing the diabetes with multiple agents at the beginning to have a good glycemic control. Not only that, if the patient presents a higher HbA1c, the effectiveness of a single agent to reduce HbA1c is rarely exceed 1%. So an initial combination therapy should be considered in patients presenting with HbA1c level 1.5 to 2% above the target. So if you are dealing with a patient who is having HbA1c more than 8, definitely go for an early combination therapy to bring down the HbA1c so that we can have some beneficial effect on the HbA1c as well as beta cell protection. This is from the ADA 2020 guidelines. So when we are treating a patient with type 2 diabetes mellitus, good glycemic control is important, as well as you should control the dysmetabolic syndrome like insulin resistance, obesity, hyperinsulinemia, hypertension, dyslipidemia, atherosclerosis, and procoagulant state. All these can prevent microvascular as well as macrovascular complications. So if you are considering a combination therapy to address diabetes mellitus, it should be able to treat insulin resistance, preserve the beta cells, which will increase the durability of the drug, should not cause hypoglycemia, should not cause weight gain, and preferably promote weight loss. It should be having renoprotective effect as well as cardiovascular benefit. And if we see the insulin resistance and cardiovascular disease, we know the common soil hypothesis, obesity can increase the fat mass, it can increase the free fatty acid, resistant leptin, TNF alpha, and reduce adiponectin, can contribute to insulin resistance, which in turn can produce impaired glucose tolerance, dyslipidemia, NAFLD, hypertension, endocrine dysfunction, inflammation, and thrombosis. All these can contribute in one way or the other way to diabetes mellitus as well as cardiovascular disease. So insulin resistance, we can say, is the basic pathophysiology behind all these complications. And we know that insulin resistance is a risk factor for cardiovascular disease, and insulin resistance promotes atherosclerosis even before it produces diabetes mellitus. So if you have a plan to treat type 2 diabetes mellitus, we should be having options for reducing insulin resistance. What are they? Diet, exercise, weight reduction. Other than that, drugs like metformin as well as pioglitazone can reduce insulin resistance. On the other hand, if you use a DPP-4 inhibitor or a GLP-1 receptor agonist, it is not having any effect on the insulin resistance as per the duration 4 study. And the second part we were discussing is regarding the durability as well as beta cell preservation. We know that there is a gradual decline in beta cell function over a period of years if you are following a patient with type 2 diabetes mellitus. So when we are using a drug which increases the insulin secretion from the pancreatic beta cells, then the durability of that drug will gradually decrease and the HbA1c gradually will increase over a period of time. On the other hand, if we are using an insulin sensitizer like a pioglitazone or a thiazolidinedione, it will be having a more durable effect because it is not directly producing the insulin from the pancreatic beta cells, but it is sensitizing the body to have effect of insulin. So it is having more durability. So you can combine this agent to any other agent. And if you see the beta cell decline, it can be because of the glucotoxicity, lipotoxicity, amyloid deposition, and protein glycation, and dysfunction in the insulin processing, as well as decline in the progenitor cell. We know that thiazolidinediones can have a beta cell preservation of beta cell function, by direct effect on the PPR gamma receptor on the beta cell, amelioration of insulin resistance, reduction free fatty acid, as well as other metabolites of lipids in the body like diacylglycerol, ceramides, etc. Reversal of glucotoxicity and improving the insulin production by proinsulin-insulin ratio, and decrease the prevalence and severity of amyloid deposition in the beta cells. So we have seen that insulin resistance is decreased by metformin as well as pioglitazone. Preservation of beta cells, which will give durable glycemic control by pioglitazone, and recent evidence also shows that GLP-1 receptor agonist also will improve the beta cell function, and it can preserve the beta cells in the long term. And the other qualities that we should be looking for should be avoidance of hypoglycemia, weight loss. And if you see the guidance from the ADA 2020, if you want to have reduced hypoglycemia, the agents preferred are DPP-4 inhibitor, GLP-1 receptor agonist, SGLT2 inhibitor, as well as thiazolidinediones. And try to avoid sulfonylurea as well as insulin, because both of these can produce hypoglycemia. And if you are having a need for reducing weight gain or promote weight loss, the preferred agents are a GLP-1 receptor agonist or an SGLT2 inhibitor, or a combination of both. And if you know that metformin as well as DPP-4 inhibitor are weight neutral, and sulfonylureas as well as insulin as well as thiazolidinediones are producing weight gain. So this is the comparison of different SGLT2 inhibitor in the real world as well as meta-analysis regarding weight loss. Canagliflozin is having more weight loss as compared to EMPA as well as dapagliflozin. In the Indian real world study, it is around 4.1 versus 3.4 and 3.2. And if you see the network meta-analysis, it also shows the weight loss of around 2.2 kg with canagliflozin, 2 kg close to empagliflozin and dapagliflozin. And this is a study regarding remogliflozin from the Indian context. What is the amount of weight loss? It also shows that 100 milligram BD dose, it can have a weight loss around 1.48 kilogram over a period of 6 months. So it is also a cheaper SGLT2 inhibitor which is having weight loss property as well. And this is a slide which is showing the difference between the liraglutide and placebo. Liraglutide can have a weight loss up to 4 kg on follow-up. So we have discussed all the aspects except the renoprotective effect as well as the cardioprotective benefits of the combination therapy. So if you see the drugs which can produce renoprotection as well as cardiovascular benefit, you can see the ADA guidance again, 2020 guidance. If you want this cardiovascular CV as well as renal effect, metformin we can say regarding atherosclerotic cardiovascular disease, it is having potential benefit. On heart failure, it is neutral, and kidney, it is neutral. SGLT2 inhibitor, it is having a benefit on atherosclerotic cardiovascular disease as per the empagliflozin and enagliflozin outcome cardiovascular outcome trials. Heart failure, it is having a class effect, and progression of CKD, it is having a class effect. And GLP-1 receptor agonist, we know that atherosclerotic cardiovascular disease, it is a preferred agent because it can reduce the atherosclerotic cardiovascular disease incidence risk in patients who are having diabetes mellitus, especially liraglutide, semaglutide, and dulaglutide as shown the same. And heart failure, it is neutral, and the progression of DKD is also beneficial in terms of reducing microalbuminuria. And this is the 2020 KITCO diabetes management CKD guidelines, and which also shows that if you use an SGLT2 inhibitor, it is having effect on the microalbuminuria, albuminuria containing composite outcome. It reduces as a class, and it protects the EGFR and reduces the EGFR loss. And if you can see the MACE outcome, the EMPA as well as canagliflozin trials have shown that a reduction in the EMPA, the MACE events, and dapagliflozin, it was neutral because it contained less population with cardiovascular disease. And this is the slide which is showing canagliflozin and the progression of microalbuminuria, 27% reduction of progression of albuminuria, and 1.7 times regression of albuminuria as per the use of canagliflozin compared to placebo. And this is the meta-analysis of SGLT2 inhibitor in composite renal endpoints in patients who are already having a cardiovascular disease versus a multiple risk factors. In both these categories, it is having benefits on the composite renal outcome. So we can say that it's a class effect which is present in both patients who already had a cardiovascular disease or having multiple comorbidities like primary as well as secondary prevention cohorts. And this is one of the landmark trial like EMPA trial which has shown that there is a reduction in the cardiovascular death, 38% related risk reduction as compared to placebo. So if you see the meta-analysis of SGLT2 trials on composite MACE endpoints, those patients who had an atherosclerotic cardiovascular disease, they were having a benefit, and patients with multiple risk factors, there was not a significant benefit. They can say that SGLT2 reduces atherosclerotic events in secondary prevention cohort, but not in primary prevention cohort. And this is regarding the hospitalization due to heart failure or CV death. It is having effect on both atherosclerotic cardiovascular disease patients as well as those patients with multiple risk factors. So here, both primary and secondary prevention cohort had benefit in hospitalization due to heart failure due to SGLT2 inhibitor. So we have seen the renoprotective effect of SGLT2 inhibitor and GLP-1 receptor agonist. And we know that recent trials also show that linagliptin can reduce the progression of microalbuminuria in patients with diabetes mellitus. And there was a previous study of sagliptin which also showed a reduction in microalbuminuria progression. And the cardiovascular benefit, we have newer trials of semaglutide as well as dulaglutide, which also showed that an improvement in MACE events with respect to cardiovascular disease. And coming to the last part of my presentation, we know that as the duration of diabetes mellitus increases, there is an increase in the number of medications because we know that if you start with a monotherapy, it will fail and we may have to take multiple drugs during the course of the illness. So when there is an increase in the number of drugs a patient takes, especially multiple OHAs, along with an statin as well as AC inhibitor, ARB inhibitor, as well as aspirin, there's a tendency that the drug compliance will reduce. So there is an increased acceptance of the combined pill or a fixed dose combination of many of these agents. So it can reduce the pill burden as well as it can increase the compliance to the therapy. So we know that there are multiple combinations available in the market with metformin as well as sulfonylureas, metformin with pioglitazone, DPP4 inhibitor with metformin, SGLT2 inhibitor with metformin. Now the US FDA also says okay with the new triple combo pill in January 2020, like empagliflozin, linagliptin, extended release metformin hydrochloride. So everyone realizes the utility of a combined pill having the efficacy of 3 drugs in a single pill, which can have the efficacy and can increase the compliance. Thereby, it can reduce the HbA1c better. So what is an ideal algorithm in the management of type 2 diabetes mellitus? It should reduce the peripheral insulin resistance and preserve beta cells with practically no hypoglycemia. If you consider that the first line agents should be metformin, pioglitazone, DPP4 inhibitor, or a GLP-1 analog, or an SGLT2 inhibitor, or a combination of these drugs. And if it fails to control the blood sugars, or if the patient's prototype is different, you can go for the insulin secretagogues like sulfonylurea or non-sulfonylurea drugs, which will produce insulin. Then you should also look at the postprandial hyperglycemia. Alpha glucosidase inhibitors will come into play. And if the patient is not responding to this one, or if the patient is having progression of HbA1c, increase in HbA1c, then you can go for the insulins. So we have discussed various aspects of diabetes and COVID. What is the need for aggressive management of type 2 diabetes mellitus? And what are the methods to address this different pathophysiological mechanism in diabetes mellitus? What are the ideal characteristics of a fixed drug combination or a combined pill in the management of type 2 diabetes mellitus? And in a nutshell, we have gone through the different agents as well. Thank you for your patient listening, and I hope I kept it on time. Thank you.
Thank you, Dr. Vipin, for a nice and lucid presentation. It was a beautiful presentation. I think some messages are very, very clear. There is no controversy or issue issue for comprehending the issue. The management protocol, it was a very simple slides we are using, and the messages are very simple. You should try to get a intensive glycosylated hemoglobin or glycemic control and other comorbidities. That's a message. And I think Mr. Naga, do you want to take the question answers now, or you want to take it after 3 sessions?
So after the session, we'll take it up, sir.
Now, I think the box is empty. Chat box is empty.
Yeah. So we will wait for the next session also to get over, sir.
I think we'll see. Bibin, is it okay for you?
Yes, sir. Yes, sir.
Okay. Now the second session, Dr. Tittu will be discussing. Dr. Tittu Umman is a very young, dynamic personality, currently working in Providence Diabetic Center, and he's a clinician and academician working in Gokulam Medical College Hospital as an associate professor now. very good administrator, and overall his capacity to organize conferences is really commendable. I think the organizing conference is a passion for Dr. Titu. Now he's the scientific committee co-chair of the Kentocon. He's doing all the work and is actively participating almost all the academic activities in Trivandrum. His interest includes thyroid diseases, diabetes, and osteoporosis. He is a very active member of an American Diabetic Association and Endocrine Society of India. And he's having a lot of publication also. Even this called junior, very, very dynamic, very promising personality. Over to Titu, please, Titu.
Thank you, sir, for the kind words. May I ask the organizers to give me the share screen rights so that I can share my presentation? Yeah, thank you. I hope my screen is visible and I am audible.
Yes, sir.
Okay, so the topic given to me is modern sulfonylurea strike back. So as you all know, because of the superstars, the SGLT2 inhibitors and the GLP-1 receptor agonists, sulfonylurea is many times now considered as a last man batting, and all of us are waiting for the last man to get out so that we can get out of the business so that we can proceed ahead. But this Vivin, an ardent cricket player, will obviously remember this. This is from the last year's Lord's Test match versus Australia versus England, where the last pair defied all expectations, and sometimes the last man batting can ensure victory. So you cannot rule out any drug at any point of the time. So today's objectives of presentation are looking at the options after metformin. Now, what is wrong with sulfonylureas? Whether we can say that all sulfonylureas, bracket all the sulfonylureas together, look at the modern sulfonylureas and try to position the sulfonylurea in the current scenario. So when you look at all the current established guidelines, whether ADA, AAC, or the ADA-ESD consensus statement, they form a pattern that you look at established atherosclerotic cardiovascular disease or DKD, or without these diseases. And if there is a presence of atherosclerotic cardiovascular disease of DKD, you have some drugs. If you don't have those diseases, you have to consider hypoglycemia, weight, and cost concern as the reason for choosing the add-on drug to metformin. So when you come into that bracket, what we are looking at is convenience, adverse effects, eGFR, age, baseline HbA1c, duration of diabetes, and body mass index. So the current guidelines sort of have given us two superstars, the SGLT2 inhibitors, the glyphosins, and the GLP-1 receptor agonist, liraglutide, dulaglutide, all these drugs. So they have supra-additive benefit to the glycemic control. That is, they reduce the risk of comorbidity and they reduce mortality. That's really good. But clinical practice dictum states that you have to use early aggressive treatment strategy, as Vivin said, using multiple medication. Meanwhile, you have to remain conscious of the safety aspects. So you should have a look at glucodynamics. Glucodynamics, it's a holistic therapeutic approach that looks at optimization of efficacy, safety, and cost. So the drug that you're using should be effective. It should protect against development of complications, and it should be had at an optimized therapy so that all people can afford it. So what's wrong with sulfonylureas? There is nothing wrong. You look at whether all sulfonylureas are the same. So the sulfonylurea hypoglycemic activity was reported in the early 1930s. By 1950, the first drug was approved, and the third generation of sulfonylureas came into market around 1995. So they represent one of the oldest and most commonly used anti-hyperglycemic agents. That doesn't mean they are outdated and should be removed. Why do they have a bad reputation? They are known to cause hypoglycemia. They are known to cause weight gain. They are known to cause beta cell exhaustion. And there is a FDA black box warning that you can have increased cardiovascular risk factors with adverse effects with these drugs. But are they all the same? They are not all the same, actually. So if you look at the classification of sulfonylureas, the older generation sulfonylureas are the so-called joelbutamide, clopromide, then came glibenclamide and glycoside immediate release, followed by the third generation glimepiride. The modern sulfonylureas are glimepiride, glycoside modified release, glyphosate modified release. And you can again divide them into based on the duration of action. But these drugs, so when we say modern sulfonylureas, we are speaking about glimepiride, glycosate modified release, and glyphosate modified release. Now, one of the major issue with them was that their receptor sensitivity, selectivity. So, as we all know, in the pancreatic beta cells, there is a channel known as potassium channel, potassium ATP channel, which has a sulfonylurea receptor. So, the sulfonylurea attaches to that. That causes the calcium influx, and ultimately you have insulin secretion. But these receptors are situated either in the mitochondria or in the sarcolemma, depending upon the tissue of origin. That is, whether this receptor is seen in the pancreatic beta cell or in the heart. Glimepiride is selective for the sarcolemmal, whereas drugs like glibenclamide are selective for the mitochondrial channel in the heart, and that may cause their problems with the heart. Similarly, glycoside attaches selectively only to the sulfonylurea receptor, whereas a post-receptor molecule EPAC is not inhibited by glycoside. This EPAC stimulation results in continuous insulin granule exocytosis. So, not even though they are a class of drug, they have very much different in their mechanism of action and receptor binding, and all drugs may not cause all of these problems as described. So we come over to the modern sulfonylureas. First, we have to see that whatever drug we use should be effective. Sulfonyl monotherapy has reduced HbA1c by up to 1.5% as compared to placebo, as seen by recent systemic meta-analysis data. So they are highly effective. So we are speaking about comorbidity reduction, but we've been rightly pointed out, you have to have intensive glycemic control. At the heart of any diabetes therapy is you should bring down the blood sugar. So sulfonylureas are effective, no doubt. What about this hypoglycemia risk? Extensive studies shown. See, even in the advanced study which had which came after UKPDS, which said that sulfonylureas have a lot of hypoglycemias, showed that the intensive therapy arm did not have much hypoglycemia with the glycoside modified release. Then you see all the RCTs taken together, meta-analysis data which came in BMJ recently, which showed that glimepiride, the pooled hypoglycemia was around 10%, and all the hypoglycemia that is generally what we fear are due to the older generation of sulfonylureas like glibenclamide. What about weight gain? Now, all sulfonylureas, none of the sulfonylureas don't have a cardiovascular outcome trial or an RCT, but the closest to an RCT of sulfonylurea that can come out is the Carolina trial, which compared linagliptin versus glimepiride. And in the Carolina trial, the results came out that initially the glimepiride group gained about 0.6, but the end of treatment, it was just glimepiride having a 1.5 kg difference between the linagliptin group. The weight gain is not so much as being with the modern sulfonylureas as described with the older generation. This is what shown by Vipin earlier, that is there is a beta cell exhaustion. So previously, the different source article which came in 2013 showed that there is a trend of worsening glycemic control after the first year, labeled as secondary sulfonylurea failure, and this was attributed to the progressive beta cell exhaustion caused by sulfonylureas. What about Carolina? Carolina nearly was followed up for 5 to 6 years. There was no end of trial difference between HbA1c. That is, obviously, it was a cardiovascular outcome trial. The glycemic equipoise had to be maintained. There was no difference in addition of insulin between the two arms. So when you earlier thought that by 1 year you will have beta cell exhaustion with sulfonylureas, especially with the older generation, now it is very well known that even at 5 to 6 years, especially in high-risk population with atherosclerotic cardiovascular disease, there was no difference even with the so-called beta cell preserving drug, the DP2 inhibitor. Then coming to the elephant in the room, the cardiovascular safety. We are all worried about, as I said, the FDA has got a black box warning about sulfonylurea and cardiovascular disease. It came with the UGDP. This trial done with tolbutamide had issues with cardiovascular deaths and sulfonylurea. The trial was a very old trial, issues in randomization, assessment of the CV deaths, but FDA made a black box warning based after this. saying that there is a possible cardiovascular risk associated with sulfonylureas. And the postulated preclinical study, postulated mechanism of this based on preclinical studies was that when you have, it's a condition known as ischemic preconditioning. So ischemic preconditioning is a phenomenon seen preclinically, experimentally, in which repeated and brief occlusion of the same vessel preconditions the myocardium, and subsequent prolonged occlusion leads to smaller infarct. So if you don't have ischemic preconditioning, then prolonged occlusion will lead to MI, and sulfonylureas seem to abolish this ischemic preconditioning, resulting in a larger infarction state. But the studies done on humans with regards have shown that glimepiride as well as glycoside don't have this abolishment of ischemic preconditioning. It is the older generation. We have even know the receptor selectivity is one of the issue which causes this, and ischemic preconditioning is not seen with the modern sulfonylurea. So the earlier studies summarize observational studies showed weak association between sulfonylureas and cardiovascular. There were no RCTs. Whichever were there were small and underpowered. Meta-analysis of the RCT showed neutral effect. Now, there was a difference between RCT, observational studies, and meta-analysis of RCT, and this confused the clinician. We have this extensive Lancet review came back a couple of 6 years back. Extremely good article if you want to read about sulfonylureas, which showed that when you assess the mortality risk, glycoside and glimepiride were associated with the lower risk as compared to the older generation of sulfonylureas with regards to all-cause as well as cardiovascular mortality. On your left-hand side, you will see the all-cause mortality. On your right-hand side, you will see the cardiovascular mortality. Then we come over to Carolina trial, which is the closest you are going to get for a cardiovascular outcome trial with glimepiride. So it's a RCT, cardiovascular outcome trial, comparing linagliptin, a DPP-4 inhibitor versus glimepiride, follow-up and observational phase. So the outcome was 3-point MACE, duration, mean duration 6 years, 6,000 participants. That's a good number. The mean HbA1c was 7.2, and 40% had macrovascular disease, and there were more than 800 Indian patients also. What did it show? The time to 3-point MACE was not different either between linagliptin or sulfonylurea glimepiride. So whether this will put an end to the controversy, an article by my esteemed colleagues Dr. Matthew John and senior Skalra sir and Daniel sir, which looked at this, looking at the data available with Carolina trial, shows that this trial should give the cardiologist confidence to use this drug in stable coronary disease, cerebral vascular disease, and peripheral artery disease. Why? Because these were the population that was studied in Carolina disease. However, its use should be limited in people with acute coronary syndrome, recent coronary events, or those with heart failure, because we don't have adequate representation or data out of this population. This has proven the cardiovascular safety as like of a DPP-4 inhibitor. And in this context, I think it is time that FDA should revise the black box warning. Do we have any RCTs comparing the so-called modern sulfonylureas? There are some RCTs comparing glimepiride with glycoside. The frank opinion is efficacy is similar, hypoglycemia is similar. Only one trial which showed glimepiride had a slightly higher risk of hypoglycemia. However, the large observational databases have limited power to show a superiority of one drug over the other. Both are safe and can be used in a variety of populations. So where will we position them? If you look at the ADA-ESD, as I said earlier, you look at CVD or CKD, then move over to, if you don't have that, then move over to hypoglycemia, weight, and the cost issue, and consider drugs. But they keep the sulfonylurea, you can see here at the third line only. So here is where your sulfonylureas are going to come. Here. Okay, so the superstars are GLP-1 receptor agonist and SGLT2 inhibitor in patients with heart failure, atherosclerotic CVD, CKD. How many of your patients are going to have this issue? I mean, very less of your patients. When you look at the general population who would meet the criteria for an inclusion of CVOT, it's a US database study which showed that People who met clinical criteria are going to be just other in embarrassed canvas or workplace population are going to be less than 10% of your general OP crowd. However, declared TB had a good amount of primary or atherosclerotic cardiovascular risk factors. They had around 40%, and you are all well aware of the declared TB results. So if you look at the guideline authorities like the SAFS 2015 or for the South Asians, they recommend sulfonylureas to be taken into as a first drug of choice, especially for their cost and other benefits. If you look at the India Diabetes Management Group, monotherapy with metformin and sulfonylurea is considered. A combination therapy, sulfonylurea is considered as a first line addition to metformin. The RSSDI therapeutic wheel, what you do is you go from the innermost to outermost, depending upon each risk factor. So after metformin, when you consider almost all areas, you will have sulfonylurea included in that aspect. There is Western data regarding the cost effectiveness of sulfonylureas. Even in the Western world, compared with metformin monotherapy, the most cost effective therapy was sulfonylureas compared with the established SGLT2, GLP, DPP-4 inhibitors, as well as insulin. So, in patients with type 2 diabetes inadequately controlled on metformin monotherapy, sulfonylureas were the most cost effective add-on therapy. So the modern sulfonylureas address the glucodynamics. That is, they are efficacious. So they give you confidence, they are safe, and they are economic. So I would wind up by saying, summarize by saying, modern sulfonylureas provide promising efficacy and safety. The evidence suggests that they are the most cost-effective second-line therapy, and they are safe from a cardiovascular perspective, as seen from the recent trials. Thank you to the organizers as well as Jabbar sir for giving me this opportunity. And as sir said, I will just remind you again about KendoCon 2020. This is the annual conference of PACE, the Endocrine State Conference. Please block your dates. You can send us a mail to kendocon2020@gmail or contact any of us, me or Vibin, for registrations. It is free registrations. It is going to be an evening. Sir has rightly pointed out, it's an endocrine mela, and you will we have international as well as national level faculty to address all your endocrine queries, hopefully. Thank you.
Thank you, Dr. Titu, for the nice and lucid presentation of the topic. It was a very beautiful topic, and you have covered almost all points related to this issue. I think so. The carrier message would be still you have definite role for sulfonylurea. Even though American Diabetic Association mentions that sulfonylurea you should consider only as a last, something like with the cost issues there. But Indian data or Southeast Asian data still support the use of sulfonylureas also for the management of type 2 diabetes mellitus. Very clearly, he conveyed the messages. I think there is no questions in the chat box. Shall I go for the third session, Naga?
Yes, sir.
Yeah.
We'll proceed, sir. Yeah.
No issue, right?
Yes, sir. We can proceed, sir. We can proceed with the next.
I think the last session is the glyptinization in India. Even though we feel that sulfonylureas has got definite role in the management of type 2 diabetes mellitus, we should look into the international recommendations also. Wherever you go, you can go for American Diabetic Association, European Society, NICE recommendation, Australia, wherever. So now the concept is changing and treatment protocol is also changing. You can call it as modern treatment or glyptinization. I would agree one of the best drug for the management of type 2 diabetes mellitus is gliptin, 100%. Incretin-based treatment is very, very useful for the management of type 2 diabetes mellitus, especially elderly individual, definitely, because we are much bothered about the hypoglycemic issues and all. But what I used to tell during my discussions, anybody can start gliptin. Okay, certain molecule, including our sulfonylurea, you should be very careful. Naga, please share the introduction slide of Dr. Jayaprakash. So so I think so it's very, very important to discuss about the role of DPP4 in the management of type 2 diabetes mellitus. To discuss this little controversial topic, and a lot of new informations are coming up in this area, we have one very good orator, good friend of mine, Dr. Jayaprakash. He is a senior consultant in Kochi. He is currently attached to Medical Trust Hospital. He is an MBBS graduate from my own institution, that is Trichur Medical College, MD from Tamil Nadu MMC in 2006, and DM from the prestigious institute in India, PGI, or postgraduate institute of medical center, that Chandigarh. And of course, he is a member fellow of American College of Endocrinology, also a very unique combination. And he's having lot of experience in managing. I think he's having experience for the last 10 to 15 years. And he's having a lot of academic backup also. And he's a regular speaker in various conferences conducted by various professional forum. That is very important, professional forum. And his area interest, unlike other endocrinologists, purely concentrated in endocrinology, that is hypersomatotropism, or you can call it a acromegaly. He is having lot of publication. In addition to that, I would like to add one more point. He is one of the, say, gentlemen to the core among endocrinologists. Over to Dr. Jayaprakash. Please take over, Jayaprakash, please.
Thank you, sir, for the very kind and elaborate introduction. It's always a pleasure to get introduced by you, because you always tell all the nice things and add on things by yourself. So let me begin by also thanking Microlabs for giving me the opportunity to be part of this academic forum. And my job has been made simple by the previous two speakers who have elaborated on the two other aspects of oral anti-diabetic therapy. They have covered most of the things, so I need to stick on to my topic only, which is regarding gliptins. And as Jabbar sir introduced, it has become a very important tool in terms of managing patients with diabetes, especially with the ease of use of these drugs. And today we'll be focusing on how vildagliptin has become the game changer in India. We know how the costly drug has become now very cheap, and the usage of vildagliptin has increased. And we look at the reasons behind that and how it will help in terms of managing patients with diabetes. So I'd be dealing with these sections: the challenges in diabetes management, ideal anti-diabetic agent, does vildagliptin fit the bill, and gliptinizing India. So we know the insulin resistance and insulin deficiency part of type 2 diabetes. We also know about this ominous octet and the various pathophysiological aspects of diabetes, which have now moved away from pure beta cell dysfunction and insulin resistance to include the other organs also. We will deal with how vildagliptin or gliptins would help in these aspects. One important aspect, or rather an important issue which we all clinicians have, is the progressive worsening of glycemic control over time. This is obviously due to the loss in beta cell function, which is part of aging, and also which is accelerated in patients with diabetes. And this slide, I think, very old slide, just demonstrating the loss of glycemic efficacy with all the available anti-diabetic medications. It mainly talks about the older sulfonylureas and metformin and insulin also. So as years go by around a decade, most of these patients are reached to that uncontrolled level, and earlier they had to be started on insulin because the only options which were available was glibenclamide or sulfonylureas and metformin. We know from landmark trials like UKPDS and DCCT in type 1 diabetes, which have shown that the good glycemic control reduces the incidence of complications. So the evidence is solid that whether it's type 1 or type 2, glycemic control, especially early on in the course of disease, would help us to reduce the complications in patients with diabetes. The problem with sulfonylurea is, again, coming back to the lack of durability of glycemic control. We know they are very good initially, whatever be the sulfonylureas. You can see the graph of HbA1c starts falling down almost immediately, and in the first or up to the second year, in most, they do well. But after that, the HbA1c starts rising. So we have glimepiride also in this, which shows that over a period of time, after 2 years, there is worsening of glycemic control and the durability is not good enough, as in the case of most sulfonylureas. So how lower HbA1c we are going to target? Again, it's a controversy. That's why we have individualized glycemic targets. HbA1c of around 6.5 to 7 is where you have the lowest risk of all-cause mortality, whether it's with oral anti-diabetic medications. This graph tells about metformin plus sulfonylurea, and on the other side, insulin-based regimes. Whatever be it, the risk of lowest mortality is when you try to keep the HbA1c around 6.5 to 7, or up to anything above 7.5, the mortality starts increasing. Anything lower than 6, the mortality starts increasing. So we need to balance out. We need to balance out the glycemic control without achieving that without hyperglycemia and without weight gain. So the mechanisms and the advantages and disadvantages, the basic pharmacology which we all know, the problems with existing drugs like sulfonylurea, which has got hyperglycemia and weight gain. Thiazolidinediones also have weight gain. Insulin also is associated with hyperglycemia and weight gain. So an ideal anti-diabetic agent, as far as type 2 diabetes is concerned, we would like to have these features. We would like to improve glycemic control and achieve target. That's the primary aim of any anti-diabetic medication. It would be good if they can address the multiple pathophysiological mechanisms, the octet which we have talked about. If it can halt the progressive deterioration of beta cell function, that would be one of the much wanted advantage of that agent. Avoidance of hyperglycemia and weight gain, again, would go a long way in terms of improving compliance. Reducing CV risk, or at best being CV neutral, is one of the important things, because we needn't, already these patients with diabetes have an increased cardiovascular risk, so we needn't want to add on to that. On the other side, if a drug can reduce the CV risk, that would be very good. It should be well tolerated. The safety data, especially long-term safety data, should be good, and it should be affordable. The common usage, last but not the least, especially in Indian patients, affordability is a big issue, because we are dealing with a lifelong therapy. So how much ever other advantage of a drug is there, if it's not affordable for the patient to whom it is prescribed, especially in this time of crisis, it is not going to be useful. So it's a big decision pointer that we all need to consider. So improving glycemic control, again, the data with vildagliptin is huge, wherein the A1C reduction in terms of patients, all patient subset. This is the comparison study with glimepiride, both as an add-on to metformin at 2 year. The HbA1c reduction was similar, with very less comparable incidence of hyperglycemia, and weight also. There was actually a 1.5 kilogram weight difference. There was weight loss with vildagliptin and metformin combination. These drugs, DPP-4 inhibitors as a whole, they are efficacious. The A1C reduction ranges from 0.7 to 1%, and there is data with these agents which tell that Asians actually do better. The A1C lowering, which is found in Asian subset, is considered to be better than the European or the US counterparts. So that we have seen in our practice also. Our patients do well on gliptins. Again, the change in A1C, this is a meta-analysis comparing all the gliptins, which have shown that vildagliptin is one of the most efficacious in terms of lowering A1C compared to other gliptins. The real-world study called GUARD study, the data from more than 19,000 patients as vildagliptin combination with metformin. They have looked into all subset of patients, elderly patients, obese patients at different baseline A1C levels. And with an A1C of less than 8, the reduction is 0.8%. With the A1C is more than 10%, you can reduce by around 3 percentage point of HbA1c. So this is showing good efficacy in the real world setting. And combination with metformin also showed comparable efficacy, 0.84 to 3.3%. So we know that it improves glycemic control and helps in achieving targets. What about addressing multiple pathophysiological mechanisms? I'm sure I need to elaborate on this graph wherein the pathway of GLP-1, which is released from intestinal cells, which is inactivated by the enzyme DPP-4, and when you give a DPP-4 inhibitor, correspondingly the active GLP-1 levels improve, and this GLP-1 levels increase the incretin response by increasing insulin and decreasing glucagon, improves glycemic control. So it is also indirectly found to have a decrease in insulin resistance, vildagliptin. One is due to the direct effect of reducing glucotoxicity. Then the glucagon effect, which is actually unique with DPP-4 inhibitors, and it is actually best demonstrated with vildagliptin, wherein it reduces the glucagon levels during meals. It is also found to reduce lipotoxicity. So all these factors help to reduce insulin resistance also. So coming back to the role of DPP-4 inhibitors or the incretin molecules in terms of addressing this hominous octet, you can see that it can improve insulin secretion, it can improve incretin effect, it can improve insulin resistance. It also has got GLP-1 receptor agonist, has got effect on the appetite, and the improvement in lipolysis and glucagon secretion is decreased. So it addresses 5 of these pathogenesis octets, and thereby it is one of the most useful molecules. What about the data regarding halting the progressive deterioration of beta cells? We have animal data. This is the rat pancreatic growth model, which has found to have an improvement in terms of the apoptotic rate and improvement in beta cell mass, which was very evident with vildagliptin. But unfortunately, it's very difficult to replicate this in human studies in live beings. So it's only indirect evidence which show that it improves insulin secretion sensitivity and the adaptation index, which is an indirect marker of insulin sensitivity. So vildagliptin, even though the human data doesn't actually, we can tell with confidence that it can improve beta cell, or rather prevent the beta cell apoptosis, but nevertheless, it doesn't add on to the burden on the beta cells, which the sulfonylureas are purported to have. Avoidance of hypoglycemia and avoidance of iatrogenic weight gain is very important. This statement, which tells that every diabetic patient could have easily achieved the target if there was no risk of hyperglycemia. You pump them with oral anti-diabetic medications or with insulin, and if there was no hypoglycemia, almost all patients would achieve that. But this is the case, unfortunately, when you try to achieve intensive glycemic control, the incidence of hypoglycemia also increases. That's that was well demonstrated in the VADT, ACCORD, and advanced trials, which tried looking into intensive glycemic control to reduce the complications of type 2 diabetes. But unfortunately, it didn't prove so. And one of the problems which are associated with intensive glycemic control is the hypoglycemia, which was seen in all these trials. So again, severe hypoglycemia, especially, is a risk factor for cardiovascular disease. The relative risk of cardiovascular event increases due to multiple factors. One of them is weight gain. One of them is probably triggering of arrhythmia. So whatever be it, avoidance of hypoglycemia is very important. And among the oral anti-diabetic medications, actually, DP4 inhibitors have the lowest rate of hypoglycemia, as along with metformin and alpha glucosidase inhibitors. So the risk factor of hypoglycemia, or the risk of hypoglycemia, is minimal with vildagliptin also. One of the things, unique things which we have discussed is the improvement in, or rather the restoration of the glucagon response with vildagliptin, which is unique with this molecule. So in response to hypoglycemia, actually vildagliptin increases glucagon secretion. So thereby it is one of the mechanisms by which it can prevent. So the exact mechanisms are not known, but it is due to various factors like improvement in the islet sensitivity to alpha cells, also apart from beta cells, autonomic nerve activation, and increased GIP levels. This increased GIP levels is actually seen maximum with vildagliptin even compared to other gliptins. So the same graph with a comparison between glimepiride, which has shown that it has a very low hypoglycemia risk, and also avoidance of weight gain. Actually, patients on vildagliptin had minor weight loss. Many mechanisms which describe this at the subcellular levels in terms of how it can avoid weight gain and how probably a little bit of weight loss is also seen. But all the trials have shown that it doesn't cause weight gain. The cardiovascular risk and the effect of these drugs on the cardiovascular system, we have safety data with vildagliptin, which is meta-analysis of large trials, which have shown that it doesn't increase the cardiovascular risk. 40 studies, again, if you see the cardiovascular risk is not increased with vildagliptin. Pooled data, there was no increased risk of heart failure also with vildagliptin. Then we have the verified trial, which have looked into the cardiovascular aspects also in patients who were started with vildagliptin initial as a combination therapy versus late addition of vildagliptin after metformin. So the macrovascular event was analyzed in this, and it was found that patients who had been started on early combination therapy did better. It was showing some benefit in terms of early achievement of glycemic control. So we know that there are no prospective trials, outcome trials with vildagliptin, but nevertheless, whatever available data, it is showing that it is safe. It is safe in patients with cardiovascular risk factors also. The tolerance of vildagliptin is well documented. We have all been using this molecule since more than a decade now, and it is actually it is the safest in terms of tolerance as far as all anti-diabetic medications are concerned. Long-term safety data, yes, the risk of pancreatitis was one of the concerns, and now over years we have seen that there is no increased risk of pancreatitis with vildagliptin versus the comparators. In renal impairment also, it is one of the safest agents which can be used. Actually, one of the advantages once renal function deteriorates to a creatinine clearance of less than 50, one advantage is that vildagliptin can be given once daily. So once daily vildagliptin is as efficacious as twice daily vildagliptin in patients with a creatinine clearance of less than 50. Compared to other gliptins, Actually, this would bring down the cost to even half. Instead of twice daily, you can bring it down to once daily. Elderly patients, again, we have data to show that whatever be the age, more than 75 years also, the adverse events are not increased. There is no increase of hypoglycemia. Other effects of the drug are also not increased. A1C reduction is also good enough. It can reduce the HbA1c of to around 1% even in elderly patients. So again, gliptins and especially vildagliptin is considered as one of the safest agents which can be used in elderly patients and elderly patients with renal impairment also. The affordability is the last in that aspect, but again, as I said, it's one of the most important aspects. And now, with the price drop which has come with vildagliptin, it has become one of the most affordable anti-diabetic medications. So, does it fit the bill? If you ask me, the recommendation in terms of the Western guidelines and also the Indian guidelines as far as RSSDA is concerned, it is the first add-on after lifestyle modification and metformin, and it's a preferred drug where hypoglycemia and weight gain are a challenge. So, is vildagliptin the game changer? Yes, if you can see the four A's, achieving glycemic control, avoidance of hypoglycemia, avoiding iatrogenic weight gain, and affordability being one of the most important factors in determining vildagliptin as an anti-diabetic medication. Thank you.
It's a very good presentation. It was a super presentation, I would say. Okay, you have lot of molecules for the treatment of diabetes. I remember when I was a student, for MD, only 1 or 2 molecules. One is dionyl. That's all, nothing more than that. After that, subsequently we got glycidates. Now you have lot of good molecules with good safety profile. Okay. So what I feel, for the safety also we have good molecules. And I think the slides were very clear and questions also very scanty. I don't know, probably because the clarity was very good for all the sessions. I see Dr. Sunil is asking a question. You want to go for liver enzyme assay before starting vildagliptin and to monitor vildagliptin treatment. This is a question by Dr. Sunil. Yes, you can.
Yes, sir. No, there is no recommendation to monitor LFTs, but the preclinical data, especially animal rat models, showed some doubt for liver toxicity in vildagliptin. There was also one of the studies which have shown that probable risk of malignancy, liver malignancy, is one of the preclinical studies. Nevertheless, this was not this. The malignancy part has not been. I think some other voice is coming in between. Yeah, now it is stopped. The malignancy part, unfortunately, has not been replicated in studies, but there is this recommendation that if the SGOT and SGPT is more than 3 times elevated, then probably this drug, vildagliptin, has to be discontinued. There is no clear-cut recommendation in terms of whether to monitor LFTs or not, but the best way to do is probably in a patient with known liver disease. It is not an agent to be used. And if you have a baseline LFT which shows that SGOT, SGPT is elevated 3 times, whatever be the cause, it is better to avoid vildagliptin.
Dr. Jayaprakash, suppose you have a patient, 80-year-old male patient, coming with diabetes. Blood sugar is 140/1 and 270. Can you just tell us the management protocol for this? So newly diagnosed, today only you got the diagnosis. How do you manage this type of patient?
I would like to have an HbA1c also. If the HbA1c is say,
I'll tell you, says 8.5 is A1C.
8.5, then I would start him on an anti-diabetic medication. If the HbA1c was less than say 7.5 for an 80-year-old with the kind of values that you had told in terms of fasting and postprandial, I would allow him to have a diet control only for the initial couple of months. But the HbA1c is 8.5, then it shows that he has probable period of long-standing diabetes, which has got undetected probably for 6 months or so. He has been having that. So that would put him under risk for complications, especially infections and all, being at this age. So in that case, egliptin would be an ideal agent. We have data with now, since we are discussing vildagliptin, more than 75 years also, we have data with gliptins, which shows that it is safe. Even though metformin is the first-line agent in an 80-year-old, especially with the appetite issues and other things, I would go for one of the safest agents being gliptin, and vildagliptin 50 milligram once daily, looking at the renal creatinine clearance, because 80-year-old, the
EGFR is 92. 92 is the EGFR.
92 is good enough. So you can start him on 50 milligram twice daily of vildagliptin. Or any other, a small dose of, if it is not controlled, one of the options is a very small dose of glimepiride also. With the data with Dr. Titu was discussing, it has also got data in elderly. But the safest agent in which we are sure that we are not going to have hyperglycemia is vildagliptin.
So Titu, what is your view? You want to give a sulfonylurea for this patient?
The data tells that there is lesser risk of hypoglycemia, but generally speaking, I mean, the hypoglycemia part, we are worried about atherosclerotic cardiovascular disease and all those outcome trials. But we are more worried about in an elderly patient, hypoglycemia causing a falls or some other issue, living alone, all these things. So in that aspect, in an elderly patient, I would agree with Dr. Jayaprakash, look at the EGFR and start on a gliptin, which, as I said, has very little other issues. So most often gliptins are preferred by clinicians because it's a write it and forget it kind of drug. You write it, and it is very rare. I mean, you would all remember a patient which you had to stop gliptin because of a side effect or an adverse reaction. Efficacy is another part, and on top of that, if still the efficacy is not met, then we might have to add a low dose glimepiride or sulfonylurea. But my first choice in an elderly patient would be a gliptin rather than a sulfonylurea.
Dr. Bibin is around? Bibin,
Yes.
what is the target glycosylated hemoglobin for this patient? You are discussing about the aggressive. Do you want to go for aggressive treatment for this patient?
So it depends upon the functionality of the patient. If the patient is active, he is not dependent on anyone for his activities of daily life, and if having a normal EGFR, he can have an HbA1c close to 7 or 7.5. So it depends upon the functional capacity of that patient. So we can have an HbA1c close to 7 or 7.5 with a lifestyle modification, the gliptins that we use, or a sulfonylurea. If the patient is not functionally very active, he's dependent on others to have the activities of daily life, we can allow him to have an HbA1c close to 8 or 8.5 without producing hypoglycemia. It depends upon the functionality of the patients.
Suppose this same patient is having some sort of dementia. What is your line of management? Do you want to change the whatever management you discussed, or you want to continue?
Yes, if the patient is having dementia, then definitely he should be allowed to have a lenient HbA1c target, like an HbA1c of less than 8.5 or 8 without producing hypoglycemia. So in that scenario, it is better to avoid a sulfonylurea because there is a chance of hypoglycemia. He may forget to have food on time, and he may have a nocturnal hypoglycemia which he may not be able to tell. So in such scenario, gliptin in full dose, because EGFR is normal, vildagliptin 2 times a day or any other gliptin will be sufficient to produce that much HbA1c. His current HbA1c, as we discussed, it was 8.5.
Yeah.
We can have a moderate glycemic control without producing hypoglycemia. That will be better for them. such
His
scenarios.
relative is working in United States of America. Okay, and she thinks that she's a good candidate for SGLT2. What is your comment, Dr. Bibin?
An SGLT2 inhibitor at this age of 80 years, even though EGFR is normal for that patient, is having a lot of contraindications, because one is at the age of 80, you will be having a lot of issues with the genital tract, like especially in a male patient can have benign prostatic hyperplasia or lower urinary tract symptoms, which it may be difficult for him to cope up with the increased frequency of maturation that he will get with an SGLT2 inhibitor. Second thing is he's having dementia. So his personal care may not be as good as a good patient who is having a good memory as well as activities of daily living. So in such scenario also, the personal hygiene will also be difficult. And third thing is he's liable for dehydration as well as electrolyte imbalance. So considering all these factors in such a patient who is having 80 years with dementia, even though the EGFR is normal, the SGLT2 inhibitor is not a good choice for him.
Any other concern if you are using DPP for drugs in our clinical practice, apart from whatever we discussed? Any other concern you have?
DPP regarding EGFR that we have discussed.
Yeah.
And second thing is whether the patient is already having a past history of pancreatitis, or if the patient is having any history of any pancreatic surgery. In such situation also, we would like to avoid a DPP4 inhibitor, even though the data is minimal, the association between the pancreatitis and the use of DPP4 inhibitor. Otherwise, we can use DPP inhibitor even if the BMI is on the lower side.
Okay, I think I say no questions in chat box now. Shall I close this?
Jabbar sir.
For the, yes,
Jabbar sir.
Yeah.
Sir, my question was specifically with regard to NASH, because as we know that whenever we check the SGLT of maybe like 50% of patients, the SGLT will be elevated. May not be like 2-3 times, maybe 1.5 or 2 times elevation. Maybe we may see in many patients. That's why I specifically put that question of baseline SGLT.
I think maybe Jayaprakash, what is your comment, Jayaprakash, for that?
Sunil, the question was whether to do baseline LFT or not.
Because,
there is no recommended.
No guidelines are there.
Yeah, but mostly as part of the initial workup of a patient before you start treatment, most of us do RFT and to look for, because NASH is also very common. Liver enzymes are also commonly done at least once. So in that case, the recommendation is to avoid vildagliptin if it is elevated 3 times or more than the upper limit of that lab value. Below that, it is safe because there are no safety concerns also with this molecule. This 3 times the upper limit is also, I don't think there is any hard data which tells that this 3 times is going to progress or any hepatic safety concern are there. But because of the preclinical animal studies have shown this, probably the upper limit is kept as 3 times. It doesn't have any outcome data to show that. Because when you have other options, better to avoid.
And that's why actually when you see with the SGLT, yes sir.
No, the issue is if you go for SCPT levels, okay, most of our patients will have little elevation of SCPT. I think that is not a contraindication for starting any molecule for that.
No contraindication, sir.
Yeah. Yes, Sunil, you are.
My understanding was that whether we should have a repeat check if you have a patient SGOT is maybe is like a 60, 56.
Sunil, I still remember
baseline
statin was introduced and pioglitazone was introduced. There was a protocol. You should look for SCPT periodically, but nowadays nobody is looking for all. Probably they will look for only one SCPT after they'll close it. Now, what is the status of pioglitazone? Pioglitazone, people will see very keenly looking for SCPT, but now we see that is a treatment for NASH. Okay, so probably in private sector it's okay, but there is no hardcore data to support repeat assay if you are starting the molecule. That's my view. Bibin also can add to that.
Yes, sir. because nowadays the prevalence of NASH and NAFLD is very common in diabetes mellitus patients. Generally, we do a baseline SGOT-PT before starting any of the drugs. Definitely, if we are having a doubt that this patient may have an increase in SGOT-PT, because if the patient is having past history of any viral hepatitis or a baseline previous history of hepatitis or a gallstone disease. Otherwise, if the patient is telling any symptoms related to liver disease, we will have a repeat LFT, which is done at the end of 3 months or 4 months. And definitely, if there is a worsening of SGOT-PT, we have to attribute to which drug which is producing. Like patient will be on statin and patient will be on different OHS. Then we can down titrate our regimen C, which is the culprit. Other than that, actually, there is no contraindication to start vildagliptin or any other gliptin in a child as ELD also. That is my understanding.
I think that we close the session now. Okay, because of the time.
Sir,
yes.
One question.
Prashant, sir.
Like in somebody with a history of heart failure, like a past history of heart failure, or somebody on gliptin, if they develop one episode of heart failure. So in those scenarios, will you be using gliptins because of concerns regarding heart failure? So should we stop gliptins, or whether we should be concerned regarding starting gliptins in a patient with the history of heart failure?
Jayaprakash, sir.
I think the data with saxagliptin is very sure that it has to be stopped. So the concern is because the mechanism of action is being similar, whether it needs to be extrapolated on to the other gliptins. Stage 3, stage 4 heart failure, again, the recommendation is to avoid gliptins. Otherwise, in that stage 1 or stage 2, gliptins can be continued, but now we have an option of SGLT2 inhibitors, which can drastically change the scenario. So if it's not contraindicated, I think it's better off shifting this patient to SGLT2 inhibitor. Otherwise, in not a decompensated, but in class 1 and class 2 heart failure, gliptins can be safely continued. The problem is, once you discontinue the drug, I'm sure we all face how the glycemic control also deteriorates, and this contributes to the worsening cardiac function also. So it's always better to continue the drug in case of it's a class 1 or class 2 heart failure.
Are you happy with the answer?
Yes, sir. Yes. Yeah.
Naga, shall we close this session and we'll go for the last part of the session?
I think, sir, we can proceed with the next session, sir. 12 o'clock, sir, as per this.
I think now thank you, Dr. Bibin, Dr. Tichu, and Dr. Jayaprakash for their excellent contribution and actively participate in the discussions also. Okay, thank you very much. Have a good luck. Okay.
Thank you.
Now we have a panel discussion now. Okay, the panelists are eminent endocrinologists across country. I think we have Dr. Anish Ghosh. He is currently, you can show the profile of the panelist. Naga, are you showing the panelist profile?
Yes, sir.
Yeah.
Yes.
Yeah.
Yes, sir. Yes.
Yeah. Dr. Anish Ghosh is a senior person. He is currently practicing at Anandaburi Hospital and he is having his own establishment in Trivandrum. He is a very good academician, good teacher, I would say, because he's a regular teacher for our DM students also. Sometimes he used to entertain our students also. Very good research person, I would say. You know why? Because he is working alone and he could manage few very good articles which is published in the ADA conferences and all. So that way he's a very good research fellow, and he's a regular faculty for a lot of conferences in ESICON, IMA, all those things, and a very active member of other organizations also. And he was the scientific committee chairman of ESICON 17, and very good in the sense, organizer. So say now we have another panelist, Dr. Tom Babu. He is a very close friend of mine. And Tom Babu currently is having his own establishment, Silverline Hospital, is the managing director of that. And what is most attractive for Dr. Tom is all the time he is smiling and he is having institute interest for teaching. His passion, I would say, that is teaching. I want to appreciate for that. His active interest in obesity, type 1 diabetes mellitus, and so. He's a very good orator also. He was the treasurer of RSS State 2010. Very good friend of mine. And we have another panelist, Dr. Sunil Menon. He's from my own place. I would say he's my student also. He graduated from Tichur Medical College, MD from Alapi, and TM from my institution, that is KM Hospital. And he backed a lot of award also from KM Hospital. And good clinician and very busy practitioner and very honest person and very sincere person. He is having a lot of publications also. Now we have Joe George. Proudly, I would say is my student. He was my student at Kottayam Medical College when he was doing MD medicine at Kottayam Medical College. He is a person with the national DNB qualification also. Did a DM from KM Hospital and said GS Medical College, Mumbai. He is a very good organizer. He was the organizing secretary of Kendocon. This time, of course, a Bipin, and he is having a lot of credentials also. So we have four. Lastly, we have Tushant Thomas. Tushant Thomas is a very silent person, workaholic person. He is now, yesterday only, he won one of the award from Endocrine Society of India. He is a very good person and highly qualified, actively interested in academics, and he was a treasurer for SCCon 2017 and is a regular face in all the academic activities in Trivandrum and Kerala. And best repurpose session 2010. Not only that, now yesterday he got one more award. So he's a perfect person, I would say, and approachable, very dedicated and sincere person. So we have 5 eminent panelists with me. The problem is what question I will ask. I'm just thinking, because all are having lot of informations, and even the delegates, their knowledge I don't want to underestimate. But still, for today's discussion, I have prepared few simple questions also. I will ask each questions to my friends, and they will take 2 minutes. And subsequently, if you want to interrupt, you can interrupt and send the question in the chat box also if you want. So with your permission, I'm starting my panel session today. First question go to, I think senior person is Dr. Anish. I will ask a question to Dr. Anish. What are the pathophysiological defects in type 2 diabetes mellitus? Anish Ghosh, please.
Thank you, sir. At the outset, let me also thank the organizers for having convened this meeting. Last year, we have had it a real session, and this time it is virtual. And I think it's a fundamental question that we identify when we start learning diabetes. We know there is a host of issues when we talk about pathophysiology of diabetes, ranging from alpha cells, beta cells, brain, adipose tissue, muscles, gut, kidney, and liver. So that forms the omnium subset. And when we talk about a multifaceted disease, we know it is very difficult to handle. It is like a complex piece of art that we are looking at. It will have its own. The viewer will have an interpretation which may differ one another. So similarly here, since we are offering several explanations into the pathophysiology of type 2 diabetes, that means probably our understanding is rather incomplete. That is what the take-home message is. When all those issues are taken into account, when we manage diabetes, how can we individualize the treatment? That is the daunting question which comes in our mind when we sit with our patients. So that is where now the branch of science dealing with diabetes management is moving into, that is precision guided management and precision guided categorization of patients from their genomics to their biological signals to their personal preferences to their hobbies, habits, etc. We are going to feed in all this information into probably a software mechanism, and we are going to custom make management which is particular to a patient, which would be best centered around a particular given individual. I think years are needed before that to reach that point. For the time being, the treatment offered is one fit for all, addressing all these issues which we discussed in Omnius Octet. I think that is my answer for it.
Very nice answer. I think the next question I would like to ask my student, Dr. Joe George. Dr. Joe, so can you just give a briefing regarding various drugs for the management of type 2 diabetes mellitus in our clinical practice? Joe, please.
Thank you, sir, for the introductory question. And I would also like to thank Micro and the organizers for making me a panelist here. So there are a lot of drugs now for diabetes, as Jabbar sir was previously saying. In the early days, even during my MBBS days and early days of my MD, it was only metformin and sulfonylurea and insulin. So historically, let me start with insulin itself. Insulin is the core pathophysiology, as Hani should have said. The basic problem with any diabetic is that there is a component of beta cell deficiency, and to correct it, insulin is the direct drug that has to be given. So insulin is something that everybody knows, and it has a A1C reduction capacity that is beyond limits. That's the only drug which has a A1C reduction capacity that cannot be counted, and it's unlimited. You can just increase the dose and reduce A1C to whatever extent you want. The second drug that came into the market and came to the people's rescue was sulfonylurea. That was around in 1965, I suppose. And we all know about the sulfonylureas. The early generation sulfonylureas had a more side effect profile, but the second generation and the third generation sulfonylureas like glimepiride and glyclazide has now proven to be cardiac neutral, so cardiac safe in that aspect with definite studies. And also they are neutral in that with the respect of cardiac failure and renal aspect. Also, glyclazide is said to be so neutral that you can even use it in a dialysis patient. The problem with sulfonylurea being the risk of hypoglycemia and the weight gain, which is there with insulin also. Then it's the metformin. It's like you don't have to talk about metformin. Metformin is the drug in diabetes. See, that is a drug that every person should be on up to a maximum dose of 2 grams per day, or whatever dose he can tolerate to maximum. It's a drug that deals with the insulin resistance component mainly, and the hepatic and muscular insulin resistance. Its main action is on the gluconeogenesis part. Again, it has so good effect with very minimal side effects, and has a long-term safety, even a coronary safe profile from the UKPDS data downwards in multiple studies, though there is no randomized control trial to prove that, and still remains the backbone of diabetes treatment and the first line of treatment in any diabetic after diet and exercise. Then came the glitazone group. The troglitazone was banned as soon as just before it was launched, and rosiglitazone was banned because of cardiac failure. But pioglitazone has stood its stand, being a cardiac safe drug, and now we have definite data to say that it is a cardiac safe drug and has positive benefits if started early in the diabetic period before any cardiac risk factor comes in. In the long run, it is having a positive effect on cardiac disease. But the problem is that it leads to some amount of fluid retention and can lead to increased risk of heart failure. Renal wise also, it is safe and you can use it in renal failure. The problem with fluid retention leading to weight gain is a major issue with that, and it is again safe from the hypoglycemia point of view. When you look from the guideline point of view, one of the major drugs that came into is now most highlighted is the SGLT2 and GLP-1 receptor agonists. These were the next to come into the market, of which GLP-1 receptor agonist in the form of exenatide came first, but it's now gone because of the cardiac safety and other data, which is superseded by the other drugs Again, it is a superb drug from the coronary point of view, having positive beneficial effects and positive neutral effects in the cardiac failure point of view. Renal also has some benefits shown by the liraglutide, and it is superb agent for weight loss, that it has been approved by the various drug control boards, including the US FDA, as a weight loss drug in even in a non-diabetic person. Again, it doesn't produce any hypoglycemia, and that's the injectable preparation. And the oral version of that is said to be the DPP-4 inhibitor. DPP-4 inhibitor, again, the difference is that it's an oral version and it inhibits the enzyme that degrades the GLP-1, the natural body-produced GLP-1 receptor, GLP-1. The only thing is that GLP-1 receptor agonist, being an injectable and it's an analog, it has a larger A1C reduction capacity of around 1.2, while DPP-4 reduces HbA1c by around 0.7 only. It's again cardiac neutral, as shown by various CVOT outcome trials, including saxagliptin is cardiac neutral. The only problem with saxagliptin is that it increases the risk of cardiac failure. But from the coronary risk point of view, it is cardiac neutral. And cardiac failure-wise, saxagliptin has a negative aspect to it. And allogliptin also has a negative aspect to it. All the other gliptins who has a cardiovascular outcome trial is said to be cardiac neutral. It's again renal safe, especially saxagliptin and linagliptin has shown in the positive randomized control trial that there is a renal reduction in microalbumin excretion with the DPP-4 inhibitor. It's weight neutral and doesn't produce hypoglycemia. And the latest to enter the market and now leading the guidelines along with the GLP-1 receptor agonist is the SGLT2 inhibitor, which increases the renal excretion of glucose. As we know, today I think a lot of one topic also was in that aspect. It has a HbA1c reduction capacity of 0.8 to 0.9. And again, very safe and positive beneficial effect in the coronary perspective, and also cardiac failure perspective, and also the renal failure perspective, and also reducing weight without producing hypo and reducing BP. So it has almost all the positive aspects to the drug that we would expect of an anti-diabetic agent, but with the negative problem that coming in the form of genital and urinary infection and a long-term possible risk of bone loss. So these are the major groups of drug. I wouldn't touch upon the other smaller groups which are also there, sir.
Very nice, Dr. Joy. It was very clearly you mentioned almost all drugs. And there's a continuation of this question, I would say. I will ask my friend Dr. Sunil. Okay. So, Sunil, if you take the drugs, I think Dr. Joy was mentioning various medication. Okay. If you are giving insulin, insulin will address only insulinopenia, right? Or if you are using, by and large, if you are using sulfonylurea, sulfonylurea will address only secretory issue. So can you just tell us few drugs which will address most of the aspects of omnis octet? Take over, Dr. Sunil.
Okay.
Sunil,
Thank you, sir.
You can move to your video because I think you have some connection problem in your center. Okay.
So am I audible?
Yeah, clear.
Okay, so thank you, sir, for the question, as well as I extend my sincere thanks to the micro team also for conducting this meeting and including me as a panelist. So as we know, the omnis octet is actually you can say something with secretion, that is with insulin secretion, glucagon secretion, and then incretin. That is three of them. Then will be glucose absorption, glucose at the level of muscle, glucose release at the level of liver, and glucose reabsorption at the level of kidneys, then at the level of brain, then at the level of fat, that is lipid. All this makes the 8 of the omnis octet. So as far as rightly pointed, the drugs which maximally address is actually the GLP-1 agonist is the strongest, which can address maximum in the maximum possible way. Maybe 5 out of 8 can be addressed in the maximum possible way. And second to that is actually the gliptins, which will address again the 5, but lesser stronger way when compared to GLP-1 agonist. As we can see that it will address the gliptins can address the insulin secretion part, incretin part as specifically, and it can address the part of glucagon and hepatic glucose output at the level of liver, indirectly by affecting the glucose. Then at the level of brain also, with respect to the satiety level. So maximally affected will be an oral drug will be gliptins as such, as we have been talking elaborately regarding gliptin today, and also the other gliptins are also available for us. And as gliptin is available in the means at a much lesser cost, I think the gliptin use of gliptin as expected is going up, which is basically it's a sound move with regard to the pathophysiology of diabetes mellitus, where 5 of the omnisubstances actually addressed at the same time, giving benefit to the patient. Sir, you are muted. Sir, you have to unmute.
So Jabba sir, you are muted.
Yes. Okay. Yeah. Okay. Sunil, it's fine.
Yes.
Thank you very much. Yeah, thank you very much. And I will ask another question to Dr. Tushant. He is having a lot of experience in managing diabetes cases. So, Dr. Tushant, if you are managing a case of diabetes, what are the major challenges in our clinical practice? Major challenges.
Yeah, good morning, sir, and dear panelists. Major challenges, I think one of the issues was the affordability issue regarding the molecules which have scientific data supporting its cardiovascular safety. But I think over a period of time, gradually the cost will come down so that we can use it in most of the patients. So that is one of the foremost issues, like affordability issues. I think regarding that, I think we cannot do much. We can wait for the time to pass by, and most probably the cost will come down. The other major issue that I face is regarding the awareness of patients regarding the importance of glycemic control, the importance of screening for complications, because that is the foremost thing, I think, regarding complications. Whenever we ask the patient to do a renal function or go for a fundus examination, they are very reluctant, like why should they go for it? Because they are not having any symptoms for that. So the awareness among patients regarding complications and their reluctance to go for screening of complications every year, that is another challenge that I face. And then to some extent, the dietary practices, the lack of physical activity, which even after stressing on every visit, still the physical activity part is very less. Even I think among doctors also it's very less. So those things also need improvement, like physical activity and the education regarding the dietary control, all those things. So there are several challenges which have been there. Things we'll have to deal with in one way or another. And now, like especially in the COVID era, what I am facing is the lack of follow-up of several patients, because I think most of the patients have they're thinking that we'll wait for some more time, and now it's almost 1 year, I think, or at least 8 or 9 months. No, patients who are coming for regular follow-up every 3 months. I not seen them for last 9 months or 6 or 9 months at least. And now when I see them after 9 months, most of them have their A1C increased, like who were well controlled, having A1Cs around 7 or 8 at the at the maximum they had around 7 or 8, but nowadays they are coming back with A1Cs 9, 10 like that. So during COVID times, they were sitting at home, the dietary habits have changed, physical activity because of the lack of facility to go out, physical activity have come down, proper testing has not been done. So most of them have developed worsening of their glycemic control. So these are some of the aspects which come to my mind regarding the challenges that we face when the management of a diabetic patient is concerned.
What about the hypoglycemic issues and all? What you want to highlight something about that?
Yeah, hypoglycemia, definitely. I think it's a part of diabetic management. Patients who are on insulin and sulfonylurea. I think Jaiprakash or Titu, I think one of them had put up a slide telling that like if it was not for hypoglycemia, we could have managed all diabetic patients very easily. And that is, I think, a very hardcore reality, especially patients on sulfonylureas and insulin. The risk of hypoglycemia is very much. So if when we have options which can which are devoid of the risk of hypoglycemia, like obviously metformin is there, then DP4 inhibitors, GLP-1 analogs, SGLT inhibitors, all of them have, and the glitazones also, alpha glucosidase inhibitors. So I think when we think about adding anti-diabetic agent for the first time and then intensifying from the first agent that we started, like second line, third line agents, when we are going for that, we should give preference to agents which are devoid of hypoglycemia. But obviously it depends on the efficacy part also. For example, if somebody has very high values like 200 fasting, postprandial 300 or 400, obviously the patient will require insulin at least in the some amount, or if a small amount of sulfonylurea would be required, because that much high glucose values would require a secretagogue or insulin to bring down the glucose level. So as far as possible, go for agents which are devoid of hypoglycemia. But if required in the clinical setting for a particular patient, go for insulin, and if we need to go for insulin and sulfonylureas, always think about starting with the lowest possible dose and then gradually up titrate. Because many times we have seen that patients are started on 4 milligram glimepiride straight away, or a fairly high dose of insulin straight away, like 30 units in the morning and 20 units in the night, something like that. So even if the glucose values are on the higher side, always try to start with the lowest possible. For example, for glimepiride, start with 0.5 milligram or 1 milligram, or at the maximum 2 milligram as the starting dose. Don't go for a very high dose initially. And the insulin also may be roughly something like 0.3 to 0.4 or 0.5 units per kg as a maximum as the initial dose. And then we can always build up from there. So always keep in mind the risk of hypoglycemia. Go for agents which are devoid of hypoglycemia at the starting. And then if required, when you're going for agents which can induce hypoglycemia, try for the lowest possible dose. That is what I'll have to tell about the risk of hypoglycemia.
I think with this background information, let us hear something about the properties or qualities of an ideal oral hypoglycemic agent. We'll listen to Dr. Tom Babu. Tom Babu, please.
Yeah. Thank you. I'd like to first start by thanking Dr. Jabbar for that very warm introduction you gave of me upfront. I don't know if I deserved such big words. Anyways, thank you. Ideal properties of oral hypoglycemic agent. I think that's pretty much the textbook of diabetology there. Sir, you're asking me to, give you a whole textbook right there. But let me just attempt that question because I think it has been deliberated in the last 1.5 hours, and I think that's precisely what we've been deliberating over. But yet, to me, I think the efficacy will be of paramount importance, because I was just thinking about this while all these points were being put out just now by various speakers. But one thing I would definitely want my drug to do is to bring that A1C levels to target. And often we are faced with high, they are the ones who come to us in the first place, most of them. We are struggling with very high A1C values. So you need your drug to do its job. It means that you need a good, robust A1C reduction. So that right there, and if you look at the drugs that we have, you can separate the chaff from the wheat, so to speak. The ones who will do it for you versus who will not. And I think you need to look at the baseline A1C levels and then decide which are those tools that you want to use. So that is A. B, obviously, you want to avoid hypoglycemia like a plague. As Tushant was saying, that's something that we dread and we do not want. So it will be a happy ending if we have something that will not produce hypoglycemia, or at least have a least propensity to do that. Then obviously the thing about weight gain is real, but then fortunately now the increasing array of drugs that we're faced with or dealing with, fortunately do not add to our woes or to the patient woes. And then ultimately, I think it is that the cost is definitely an issue, but then fortunately now with the generics coming in, the costs are tumbling, so it's good for the patient, it's good for us, so we can extend cutting edge science to a large population of our patients. So therefore it's all good just now, and it probably gets better in the horizon. So exciting times for us endocrinologists is what I would say. But ultimately, I think we should do no harm. So therefore, when you pick a drug, make sure that it will do no harm. And there's a lot of science out there, arguing back and forth on these lines. So we need to watch out for that space and be informed that one thing, even if we do not do anything, but do no harm. And that's my take, sir.
Oh, it's a good point. I think, say, at least, don't do any harm. That's a very important message, right? So let us go for the next question to Dr. Anish. Dr. Anish, for the last couple of years, lot of experience backing the vildagliptin efficacy and safety. Dr. Tom was emphasizing, do not harm the patient. Okay, so in this, the background of this much information, like verified study, all those things, do you think vildagliptin is a superior gliptin than teneligliptin? Probably the quote is the cheapest gliptin, something like that. What is your views?
Yeah. Hi, sir. I suppose I'm audible now.
Yeah, you are audible.
I always believe gliptins can initially be classified in two. One, gliptins having a good pedigree line, and another one is gliptins without a strong family line. So in the first group, I would, as you all know, we have vildagliptin, sitagliptin, saxagliptin, and these gliptins, and linagliptin. And the other group, we have there used to be a couple of gliptins from Korea, and we have telenigliptin. Now, having said that, you look at the reams of data available in the scientific literature. If you weigh it, you see that 95% of data is with these 4 or 5 gliptins with pedigree, and telenigliptin in that context would stand alone, stripped of all the titles. If you consider the data behind, it cannot boast of cardiovascular safety data. There is nothing under its belt to take tall claims. It has no data to claim about the albuminuria reduction. All what we have as far as telenigliptin is concerned is the efficacy. There are a couple of good trials under its belt comparing the efficacy with many other gliptins, especially sitagliptin. And I think there is a paper comparing telenigliptin with vildagliptin as well, where it has been proven that telenigliptin is as efficacious as the other gliptins. But as Tom said, the efficacy acquires paramount importance when we talk about any anti-diabetic agent. But is that all alone that we need to look at when we talk about prescribing a drug? No, we have to weigh that efficacy against the safety as well. So we need to, we are yet to see safety data for telenigliptin. I think it has been launched in Indian market about 5 years ago, maybe 4 years ago. But as of now, if you look at the data point of view, there is no additional data since it's launched in India or elsewhere. There is no additional data which is coming up. So that is a point of concern for us. If we need to take telenigliptin quite seriously, without doubting its credibility, we need to have cardiovascular data. I think that is very important. Be it pancreatitis, be it liver issues, be it cardiac issues, the jury is still out there. The drug is still in the woods. It has not cleared the air around. So I think you can only compare an apple with an apple. You can't, but that is not the case when you compare vildagliptin and telenigliptin. And at this point of time, I would say that telenigliptin is no match for vildagliptin. That is my answer.
I think it's a good answer, correct answer. I think it's a example is very clearly showed that see, you can't compare certain things. All right, okay. I will ask another question to my friend Dr. Joe. See, Joe, you heard about Dr. Anish's discussion. Do you think you should choose vildagliptin as a molecule for gliptinization in India, especially with the affordability issue has come down. What is your opinion? What is your view?
Yeah, in India, sir, in India, cost is a major issue as most of the patients are paying, almost all, I think. In the OPD basis, almost all the patients are paying from their pocket. So cost is a major issue, and the affordability for a higher cost drug becomes a costly drug makes itself limited to maybe less than 1% of the Indian population. From that aspect, when you see cost as a major restrictive factor, that was one reason why teneligliptin became very popular when it was launched, because it was launched at a cost of 10 to 15 rupees per tablet and became a all India hit very soon. Now with vildagliptin being launched at even a lower price and being available even at 4 rupee, 5 rupee, I think when you think of the gliptin, yes, currently vildagliptin stands a chance as the best gliptin available for the masses in India to control the diabetes once they are the metformin is not enough to control the glycemia. But again, the positive aspect to that is that in the coming years, even the other gliptins are going to be off patent, and we hope that the gliptin market is going to hot up with all the companies coming out with most of the gliptins, because even now most of the companies have come up with both teneligliptin and vildagliptin, and in the same way the other gliptins also would come down, and it would be very easy for us to prescribe the best drugs from the gliptin perspective to the market. For currently, vildagliptin being a good drug, very effective, has good enough data, as Dr. Anish has pointed out, is the best for our masses.
Then so Dr. Sunil, what do you think about, let's say, he is emphasizing that vildagliptin is a good molecule and you should start giving vildagliptin for all patients with diabetes. So what is your comment about something like you heard about legacy effect? And of course, when we were students, we were discussing UKBDS data, legacy effect. Now, see, there are a lot of studies also coming up. So what is your comment about the legacy effect of vildagliptin? Do you want to discuss something about legacy effect? Please, Dr. Sunil, please.
So actually, means what legacy effect, what I understood is the legacy effect of starting treatment at a very early age, early time.
Starting,
if that is correct.
Yeah.
So then we have studies like the vildagliptin metformin combination recent study which has come saying that if you start it early and get a better diabetic control, then we'll be able to replicate the legacy study, that is the verified study which has come out. Legacy can be like we can just emulate that in the coming years. Legacy can be shown. So I don't know whether we'll be able to give gliptins to all the patients, but those patients who are correctly indicated, that is, as Dr. Tom has already told, less harm than more good. So if you are able to identify the correct persons to start gliptins, and if it is available and in an affordable price, like vildagliptin can be used, because it has got a lot of data addressed to that, even though it doesn't have a dedicated cardiovascular trial. But there are so many observational trials associated with vildagliptin showing the cardiovascular efficacy also. So with all these aspects taken into consideration, and with the cost factor which has come down now, vildagliptin can be considered as one of the gliptins which can be used in a properly chosen patient in a wide manner, so that we'll be able to cater the molecule to large number of patients, so that the overall diabetic control can be made better, and long-term complications can be reduced, and the legacy effect can be shown in the time to come.
It's a correct point. I think it's legacy effect is described by Dr. Sunil. It's very good description. See, we'll ask Dr. Tushant his opinion regarding, see, when you look into the verified trial, so they were discussing a lot of things about legacy effect, all those things, and efficacy also they were discussing. So with the background information of verified trial, how does it impact the day-to-day clinical practice? Dr. Tushant, what is your view?
Yes, sir. Verified trial, I think it had a very good design. Like they were looking at actually one of the most important aspects of that study was the long duration of follow-up, like 5-year follow-up data was there for relatively newly diagnosed. Like the inclusion criteria was less than 2 years of the diagnosis of diabetes, and then patients who are treatment naive or on metformin for the last 4 weeks only. So they are like fairly newly diagnosed diabetic patient and almost treatment naive. And in that group, they had given vildagliptin with metformin as the initial therapy as compared to metformin alone, and then sequential addition of vildagliptin, and they compared these aspects. So the first comparison was between metformin and vildagliptin metformin combination, and then the second comparison was between starting with a combination therapy and comparing it with a sequential therapy. So in both these aspects, actually, the initial combination therapy proved very good. Like if I remember correctly, I think vildagliptin with metformin combination as opposed to metformin alone, the treatment failure was 3. I think the difference was almost more than 2 years, I think. And 50% reduction was there in the patient who had treatment failure initially. That means metformin failed by around 3 years. Vildagliptin metformin combination failed by that means failure was by 2 consecutive A1Cs more than 7% on 3 months apart. So that was a definition of failure also. So the initial combination could maintain A1C less than 7 for up to 5 years almost. And it was not alone 5 years, more than 5 years. So 62 months was the median failure time. So verified trial in several ways showed the efficacy of an early combination therapy. So we should aim for early aggressive management, especially in patients with a higher baseline A1C. So if somebody has a baseline A1C of say 8 or 9, usually monotherapy may not work for that patient. So at least in such patients who are having a high baseline A1C, for example, more than 8, we should always aim for an early aggressive therapy so that we can improve the durability of the combination. We can maintain glycemic control for a long period of time. And sequential addition of other agents may be delayed by at least 1 or 2 years or 2 or 3 years if you go for early aggressive therapy. So my take from verified trial would be that early aggressive therapy is warranted at least in more than 50% of our type 2 diabetic patients, and that can help in maintaining glycemic control for a long period of time, and that can help in improving the legacy effect, because as you may recollect, the legacy effect showed that early glycemic control, especially the tight glycemic control in the initial 1 decade of diagnosis of diabetes, that can help in reducing the complications for the patients in their future life. So I think verified trial has shown definite benefit in early aggressive therapy, both in terms of maintaining good glycemic control, the durability of the initial combination therapy, and on the legacy effect, it has shown its benefit.
Good, Dr. Tushant. I think that's a correct point. Now, see, even though we discussed, so you should not start sulfonylurea and all, okay, as per American group. So we'll ask Dr. Tom. Uncontrolled diabetes is very common. Even ICMR data recently published, 45% of the patients with diabetes, they are not achieving their classical target or magic figure of 7. So Dr. Tom, what do you think about the combination of glimepiride and metformin combination and the efficacy and its future perspective? Dr. Tom, please, can you just take up the question now?
Yeah. Yeah. So I think that irrespective of what the West says, glimepiride definitely a role in our context because it's when I to the previous point that I was making, that we need to bear in mind to what extent we need to to goal. So you're talking about, say, somebody comes to you with an A1C of over 10% and you want to bring it down to 7%. How are you going to do this without sulfonylurea? So I think that we have what we have, and to some extent, I'd be interested to know what the West thinks, but then I dispense with what I have in my fold, and I think sulfonylurea definitely is in the horizon. It's going to be there for some time to come, and I don't see it going away. But having said that, I think what I see in my practice, I don't know if you agree with me there, that when you started, depending on our patients, each person responds to the sulfonylurea in different ways. Some of them are super sensitive, so the blood sugars come down very quickly, but some of them do not. So I think we must bear in mind that when you start a sulfonylurea, you must remember that it's a potent agent, and therefore in a drug-naive patient with a high A1C level, you have to think of an A1C node, a sulfonylurea, no doubt. But when you dispense with it, you need to bear in mind that some of them can super react. So you need to start cautiously, maybe start with a 0.5 or 1 milligram, and then work your way up or down. And that's the way about it. And we have cardiac safety data also now with glimepiride and glycoside. So that's one as far as sulfonylurea is concerned. So from an Indian point of view, it's hard to ignore a sulfonylurea, at least for some years to come. And this is my view, sir.
I think that's, I fully support the views of Dr. Tom, because you can't write off your old friend, even though people saying that it's not a very ideal one and all, but we can't write off this molecule. I think it's high time to listen to Dr. Anish also. Dr. Anish, for the management of diabetes mellitus, what is your concept? Is it a glucose-centric or glycemic control-centric or organ protection centric management? And what are your comments regarding the results of Carolina trial also? Can you just tell us something about these two aspects?
Yeah, actually, if you look at the fundamental concepts of diabetes management, I think it evolves around chasing sugar. We always chase sugar with imperfection. So, and right now we stand on a firm ground, knowing that if you chase sugar to perfection, the rest all will fall in place, be it microvascular complications or macrovascular complications. You can't go the other way around. First you protect organs and then you chase sugar. I think it has to be the right way. That is, you chase sugar first and the rest will fall in place. And regarding the second question, is what is the outcome of Carolina trial? I think if you look at Carolina trial, it is one of the long-term trials we have seen from DPP inhibitors point of view. I think it was the mean duration was somewhere 6 years or so. And there were close to or more than 10,000 patients, if I remember right. So who is the beneficiary? I would say that till Carolina was published, all the sulfonylureas, including glimepiride, at least for glycoside, there was advanced trial to lay back, to fall back. Even though it was the renal composite, in the composite outcome was largely driven by renal endpoint, but still there was something to fall back upon each time when the question was probed, or the question was posed regarding the cardiovascular safety. But there was nothing that sort of for to come to rescue glimepiride until Carolina was published. But now Carolina is a windfall gain for glimepiride, and glimepiride could regain its lost ground. Now it can stand firm on its feet and deliver, because like advanced to protect glycoside, now we have Carolina, which is a trial which was done in a bigger dimension than advanced trial. So now I have seen, in fact, companies promoting glimepiride based using this Carolina as a way to convince clinicians to take up glimepiride in a bigger way. So this is my answer pertaining to your question.
Good, Dr. Anish. Now we'll change the topic little. All right. Okay. So far we were discussing little about sulfonylurea, little about DPP4. Now we'll move to the next group of drug, SGL2. So Dr. Joe, what are your concepts or what are your ideas regarding SGL2 inhibitors for the management of type 2? What are the benefits? What are the demerits? Can you just enlighten us? Over to Joe.
Yeah, thank you, sir. Actually, in my first answer, I have touched upon this point. SGLT2 is the latest in the major class of drug that has come to our rescue and our patients' rescue in managing the diabetes. And it's a very strong drug, powerful drug. It has A1C reduction capacity of around 0.8 to 0.9. And also, it has a unique mechanism of action that is not shared by any other class of drugs which are currently being used. Like it increases the glucose excretion through the renal tubules. So it doesn't interfere with the other mechanisms of action, and it has an additive benefit with any combination that is being used. These are the advantages that initially we thought of when the drug was launched. But we were always worried about the side effect profile that it could happen, because early studies suggested some negative effects in the genital urinary tract and the urinary infection point of view. But once the EMPARAG outcome trial came and followed by the CANVAS trial and the DAPA trial, the efficacy, in addition to the glycemic efficacy, a lot of positive benefits have been found and confirmed with this class of drug. With canagliflozin and empagliflozin, there is a definite evidence, proof of evidence that it improves the coronary risk of the patient. The 3-point MACE has shown to be improved, and there is in addition to the glycemic benefit. See, we all know that when the HbA1c comes down, the patient gets the benefit not just from the glycemic point of view, but also his risk profile comes down from all the aspects, from the micro and macrovascular perspective. But whatever that is provided by the glycemic reduction, in addition to that, a supra-added benefit of cardiovascular benefit is provided by the SGLT2 inhibitor, especially by the empagliflozin and canagliflozin, by the trials that have been proved. In addition, the heart failure has been a major advantage with this drug class, and it has been shown that it is a class effect with all the drugs which have undergone the CVOT trials, including ertugliflozin and dapagliflozin, and all of them have shown benefit from the heart failure perspective, which is a class effect, though the ASCVD risk reduction is not been attributed as a class effect. In the in the renal perspective also, it's beneficial, and it has been shown to be beneficial in all the stages of renal failure, from the microalbuminous stage to the macro and to the early stage of renal disease. Only problem is that we are not supposed to use it when the creatinine clearance is less than 30, but in others, in every stage, it improves the renal outcome also. It is positive effect on weight, which it has a positive, produces significant weight loss to the tune of 3 to 4 kg on an average. It does not produce hypoglycemia. It has a positive effect on weight, BP, blood pressure also, both systolic and diastolic BP. But all the positives said and done, the negative effects which initially worried us still remains. That is the increased risk of genital infection and urinary infections. So initially when it was launched itself, it was associated with a clear-cut warning to say that the patient has to be careful about his genital and urinary hygiene, and that still remains. And also some trials have shown an probable increased risk of stroke risk, and also the probable increased risk of amputation risk, but which has not been substantiated in the further follow-up studies and follow-up data. And also a long-term risk of bone loss is also something that has been suspected of this class of drug. Thank you, sir.
Thank you, Dr. Joe, for the nice comments. And we'll have few quick question answer sessions. Dr. Sunil, what do you think, if you want to add, if you are starting SGL2, you want to modify other drugs, or hypoglycemic agents, including insulin, I'm asking you. You are adding SGL2 to existing molecules.
If you're adding SGLT to the existing regime, it is better to reduce the dose of those drugs which actually act directly on insulin, like insulin as well as sulfonylureas. Other drugs, there is anti-diabetic drugs, I say, there is no need to change as such. So if you have a patient whose HbA1c is very much controlled, like the present guideline says that you have to include the SGLT inhibitors to the existing armamentarium, even if your HbA1c is controlled, especially in a patient who is having existing heart disease or proteinuria, especially major protein, more than 300 milligrams of albumin creatinine. So if you have such a scenario, it's like if your HbA1c is very well controlled, maybe you have to reduce the existing drugs maybe up to 20 to 30% of sulfonylurea or even insulin when you add on this the newer class of drug SGLT2, so that the possibility of a hypoglycemia which can happen to these patients while on SGLT inhibitors can be reduced. practically, I reduce the dose of like sulfuric as well as insulin in all the patients which I add, even if the patients have control HbA1c, even if they don't have control HbA1c also. I tend to reduce and ask them to by 20 to 30%, maybe around 20%, and then ask them to check the blood sugars after 1 week. And if the sugars are controlled, they should continue the same dose. And if the sugars are not controlled, they'll have to step up the dose of either the sulfuria or the insulin which they are on, so that the glycemic control can be brought back to this to the what the patient was having previously. So despite of having high control or uncontrolled blood sugars, and also I see that I generally don't start SGLT inhibitors to those patients who have blood sugars are more than 300, because as such the blood sugars with more than 300 they have having glycosuria as such, so that there will be some sort of dehydration which we may not be able to clinically we may not be able to pick up. And when we add SGLT inhibitors upon that to those patients who are having blood sugars more than 300, it may again add on to their dehydration, which may have an effect on their subsequent creatinine clearance or creatinine. So personally, I feel that we should bring down the blood sugars to less than 300 or 250. Then add SGLT inhibitors, reduce the dose of existing sulfonylurea or insulin, whatever they are on, and continue to monitor their blood sugars as well creatinine, so that it doesn't go up. And there are certain patients who creatinine do go up while on SGLT inhibitors, so that has to be we have to be careful also.
Tushant, see, now it's a very clear message, okay? And do you want to, or is it possible to combine DPP4 plus SGLT in your clinical practice? Is it an acceptable combination? It's a quick question.
Yes, sir. The combination is a very acceptable one, both in terms of efficacy, because you get almost added benefit. Like if you combine these two, I think you get something like 1.5 to 2% reduction in A1C, at least in the range of 1.5 you get. So efficacy wise, it's a very good combination. And side effect wise also, I think there are some data to suggest that when you are using this combination, as opposed to using SGLT inhibitor alone, the incidence of genital mycotic infections are less when you go for a DP4 inhibitor with a SGLT inhibitor combination. So both in terms of efficacy as well as safety part, this combination is a very good one. The only concern would be regarding the cost. When you are combining these two, actually the cost of molecules will further go up. So barring the cost, I think this combination is a very good one. The only other thing is regarding this combination, there are no major outcome studies which are available. I think some of the studies with A1C and safety part have been done, and that appears to be promising.
I think Sir Dr. Tushant was discussing something about the cost factor. So let us hear Dr. Tom. See, SGLT2 molecule is available with probably single-digit amount. Okay. So what is your comment? Is it a very suitable molecule for our group of patients? And if not, what are the limitations of SGLT inhibition compared to DPP4 inhibition for its wide usage in our clinical practice? Dr. Tom, what is your comment?
So it is a fact as it is the most prescribed drug in the world, anti-diabetic drug in the world. It has become one just now. So we're increasingly using SGLT2. But at the same time, I think there should be a word of caution that it is not that it can fit all. You need to choose your patients, because we know, and we've been discussing this in this forum, as we've been discussing in other forums, that it has its share of problems, including euglycemic ketoacidosis. So if you choose unwisely, and if you're not careful in recruiting that patient for the SGLT2 therapy, irrespective of the cost right now, is that then that may not be the way to go. So yes, if you choose your patient wisely, then this group can be a very effective group of oral drugs, and that is why it is becoming very popular in the world, and rightfully so. But having said that, I don't think it is for all. Like and unlike a DPP4 inhibitor, which appeals to a larger group of diabetic patients. But I think SGLT2, you have to choose wisely. Otherwise, we can get into trouble with these patients. Yes, we have to delve a little more, dig a little more into the profile of our patients and ask these questions as to why are we adding this agent? If we do, is the patient worse off or better off, etc., etc. So such a due diligence has to go into choosing an SGLT2 in these patients. But having said that, it's a wonderful group of drugs, and if chosen wisely, it can be a workhorse.
That's a good comment. I think we should discuss something about COVID-19 situation also. Okay, Dr. Anish, what is your opinion regarding the glycemic control? Do you want to go for a strict control or less strict control or acceptable control in this pandemic phase of COVID-19? Those who are having positive result or positive COVID positivity?
I think to answer that question, I need to refer two articles came up in Times of India over the last maybe 2 months, both from ICMR. So I can quote that news in this forum because it is from ICMR. Number one was they looked at an epidemiological study was conducted countrywide, and they looked at the deterioration of blood sugar among diabetic patients from April till September. So they found that there is on an average 30 milligrams increase in blood sugar levels, which is equated to about 1.1% deterioration in A1C. So as Tushant said, it is a huge challenge faced by treating consultants as well as patients, that indeed blood sugar levels have had significantly deteriorated in this last 7-8 months. Now, let me also bring your attention to the next point, next news clipping, again issued by ICMR. If you look at the COVID infected patients in total and categorize them based on morbidity attached to the disease, one can easily decipher that if you put together hypertension and diabetes, then about 60% of patients, or close to 60% of patients who were infected with category C COVID infection, were having, in fact, are having hypertension and diabetes. So the take-home message from here is diabetic patients are more prone to COVID infection, number one. Number two, they are more prone to get severe infection requiring ICU admissions and ventilatory support. And number three is the mortality rate is about 2-fold high among diabetic patients as compared to non-diabetic counterparts. So these are the take-home message. So having said that, it is imperative on our side to convince our patients to stick on to their treatment, do more glucose readings at home, and also utilize, exploit all means, whether it is virtual medium or face-to-face consultation. They should be in touch with their clinicians and treating healthcare providers, and they should pull out all stops to maintain their euglycemic status. By doing so, even though there is no hard evidence that they can reduce the risk of infection, which is hard to say, but we can always, with the available data, we can say that the severity of infection and mortality can in fact be reduced. So that is my take on your question. Thank you.
I think, Dr. Joe, why don't you comment about using these SGL2 versus DPP4 in the management of COVID positive patients?
See, when the patient is COVID positive, I personally wouldn't think of starting a SGLT2 DPP4 inhibitor, because we know that more than 90% of the patients just remain asymptomatic or mildly symptomatic, and there shouldn't be any risk of starting any agent there. But if the patient is having a hyperglycemia, the COVID-19 has been shown to be associated with a high level of insulin requirement and insulin resistance that has been unaccounted or unexplained partly, and to some extent explained by the mode of action, which may be through the DPP4 receptor and ACE2 receptor. So the COVID-19 scenario, when the patient is COVID positive, there is often a scenario which is where there is a high requirement, hyperglycemia that is coming up with a very high insulin resistance and high requirement for insulin. So if a patient who is COVID positive comes to me with hyperglycemia needing an additional management, I would be very comfortable starting insulin only. I wouldn't be starting any other group of drug. But on a non-COVID patient, I would be managing like any other patient, even in the present scenario.
I think that message should be emphasized, because any acute illness, you have the control with insulin, not with the OHS. Any patient, even ICU, better to go for insulin. There is no doubt about that. Now, see, I will ask another simple question to Dr. Sunil. Sunil, you remember in our Trichur Medical College, we used to go for urine sugar assay. In KM Hospital, we were using the strip method for glycemic monitoring. Now there are a lot of things are coming up. Of course, glycosylated hemoglobin is there, and TIR, time in range. Hello? So what is your comment? Or what is, yes? Gogulananda, what?
Yeah.
Why interruption? Any issue?
No, sir. Sorry.
Yeah. Okay. Dr. Sunil, what is your comment about the TIR, time in range versus glycosylated hemoglobin? You can you just enlighten us, what is the difference? What are the merits, demerits of all these issues? So, Sunil, are you around? Okay, so the thing is, glycosylated hemoglobin will give idea about the glycemic control for in the last preceding few months, 3 months. And time in range, not for all patients. In selected group of patients, you can go for CGMS or flash, and you can assess the time in range. Of course, these are all good investigation in certain group of patients, really useful in our clinical practice. Still, our blood sugar as well as glycosylated hemoglobin is the best methods for assessing glycemic status in routine practice. In difficult cases, definitely is useful, but probably after sometimes, after a few years, you will look for TIR in all cases. It seems to be a promising one. Okay. Now, I will ask another question to Dr. Tushant. What is your comment regarding the utility of CGM or flash system in our clinical practice for assessing the glycemic control?
Yes, sir. Use of CGMS, I think, I don't think all the patients need to be monitored with a CGMS. I think like when somebody comes with an A1C of say 10, 11, 9, something like that, and high glucose values at in the lab or based on glucometer reading, I think we can try to achieve A1C control first through proper treatment. So I would go for CGMS in certain select patients. Like for example, type 1 patients, I think many of the patients would benefit from going for a CGMS. Whereas in type 2 diabetes, in patients who are having very good A1C control, then if you are suspecting that patient is having uncontrolled hyperglycemia in between or unexplained hypoglycemic symptoms in between, like early morning headedness, unexplained loss of consciousness, such scenarios which warrant investigation for a possible hypoglycemic episode, we can go for that. Or somebody showing rapid deterioration in the microvascular complications in spite of good A1C control, that may be related to the glycemic control in the past also, but somebody having such scenarios. So somebody showing very good glycemic control now, but still showing some other indications to go for more vigilant monitoring of glucose values, I think I would go for CGMS. Whereas in somebody with A1C, very high glucose values, very high from the lab and home, then there obviously no point in going for CGMS at that point of time. We can achieve good glycemic control initially and then maybe go for CGMS later. Then another scenario in which I would go for CGMS would be a patient coming with say A1C of 9, 10, something like that. But on the day of testing from the lab, the glucose values are say fasting is 110 and postprandial 160, 170. So those two are not going together. indiscrepancy between the A1C and the lab values, then also we can go for a CGMS. So I think in type 1 patients, most of the patients would be an ideal candidate for CGMS at least once in a year or once in 2 years, something like that. In type 2 diabetic patients, in select patients like the patients whom I discussed, I would go for a CGMS, not in all patients. Because of one is the two limiting factors would be the affordability and availability. Because of both these issues, I think in select patients, I would go for that.
I think time to stop. Before closing, Dr. Tom is conducting teleconsultation, right? Dr. Tom, what is your experience with the teleconsultation in the current time, like in a pandemic phase, and even after settling this pandemic phase? What are your thought process? Please tell us.
I think the COVID pandemic has put into spotlight the various mediums that we can use in engagement, because engagement is has been a big problem, has been, always will remain. So what it has taught us is that we have more tools or avenues at our disposal to reach out, and this is what telemedicine has become today. But having said that, I would never solicit a teleconsult. Teleconsults will happen because of want of anything better, or when somebody has no choice but to reach out to us, and we are available, so that we are there to reinforce or to guide them. But otherwise, I would never encourage somebody to sit at home or I would never solicit a teleconsultation, because it has its limitations. But at the same time, my prediction is that we will have a hybrid model where we will have one or two face-to-face consultations, and then the third one may become a teleconsult or a video consult. But then what is most important is that irrespective of whether it's a teleconsult versus face-to-face consult, documentation, obviously, if it's a face-to-face consult, we are very familiar with the documentation and the importance of it. But the video consult also should pretty much double as a face-to-face consultation in terms of how we document these things and how we send out a proper prescription, and we send out an e-prescription to them, and to make sure that the whole loop is complete. And we should understand the sanctity of such a medium, and only if we realize how sacred this is, and it only doubles up. It does not replace anything, but it only doubles up as in these period or during this time of the pandemic, and even after that, for those people who cannot reach out to you, then it doubles up for our face-to-face consultation, but it cannot replace a face-to-face consultation.
I think that last sentence is very important, is that won't replace a physical consultation. Of course, you can have little adjustments, but that never replaces the consultation. I think because we are already finished 2 hours and 45 minutes, a time to stop it. Before closing, I say on behalf of entire my team, Chitu, Vipin, Jayaprakash, Anish, Tom, Sunil, Joe, Tushant, I express our sincere gratitude and thanks to Micro for the excellent platform provided for us for exchanging our ideas. And as a chairperson moderator, let me sincerely thank my friends for that time. They were sitting here for the last nearly 3 hours. Okay, sincerely I thank each one of you for the time and contribution. And with this, let me sign off, and I will hand over and before concluding, special thanks to Mr. Srinath, Murthy, Naga, and Prabir for excellently arranged the meeting and the excellent coordination between faculties. Thank you very much. I'm handing over the mic to Micro Pharmaceuticals for their official vote of thanks. Thank you very much.
Thank you very much, sir. My name is Murthy. It's my honor to give you a vote of thanks. As the unknown quote says, a physician treats the disease, and the great physician treats the patients with the disease. My sincere and heartfelt thanks to all the great physicians, and my pranams to our moderator, Dr. P.K. Jabbar, for his clean and crisp moderation of this wonderful proceeding. My thanks to Dr. Vipin, Dr. Titu Oman, and Dr. Jayaprakash, and Dr. Anish Ghosh, and Dr. Tom Babu and Dr. Sunil K. Menon, Dr. Joe George, and Dr. Tushan Thomas for their wonderful deliberation and participation for this wonderful program. My sincere thanks to all my colleagues, Kerala colleagues, who are headed by Mr. Praveen and also Mr. Prajil. And my thanks to Mr. Nagaraj, Mr. B.R. Srinath, and of course, my sincere and heartfelt thanks to our CMD, Mr. Dilip Surana, who has always encouraged you to do this type of academic programs. I thank each one of you, and also thanks our digital partner, RX Group. Thanks a lot, and thank you very much, sir. And thanks for taking your time and sharing the academic knowledge with all of us. Thanks, sir. Thank you so much, sir. Thanks a lot, and pranam, sir.
Pranams from us also
Thank you
here,
very
sir.
much.
Thank you, sir.
You too. Naga, thank
Yes,
you very
sir.
much.
Thank you, sir. Thanks a lot, sir. Thank you, sir.
Thank you.
Thank you, sir.
I'm
Thank you,
signing
sir.
off. Once again.
Sign
Yeah,
off.
yeah, yeah. Yes, sir. Yes, sir. Thank you, sir. Thank you, sir.
Nagaraj, very good program, Nagaraj. Beautiful.
Yeah. So, and also I would like to thank the marketing head, Mr.
Thank you,
Gokul,
Dr.
sir. He
Sunil.
has done
Sunil,
a relentless,
Gokul.
effort, sir, because he has made it possible today, starting from, preparing this program and creating all the scientific, slide deck and assisting everything. Thank you so much, Mr. Gokul, and
Thank you.
Thank
the
you,
entire
Gokul.
PM's
Thank you,
team,
Gokul.
Mr. Manas,
thanks,
Mr.
Mr.
Shubha.
Gokul. I am sorry,
Very
I
good.
just not mentioned your name.
No problem.
Yeah.
No problem.
Yeah. Thank you, boss. Thank you, Mr. Murthy. Thank you,
Thank you.
Praveen.
Thank you.
Thank you, Prajil. I
Thank
think it's
you.
all of
Refreshing,
you.
na? What a
And,
Sunday. Refreshing
and
Sunday.
Praveen and Prajil, please follow it up once again and see that the things are falling in line.
Yes, sir.
Okay?
Yes, sir.
Right.
Thank you.
Thank you.
Yes,
So
sir.
much. Thank you.
Sign off.